Mira,
Ok. Hola, ¿qué tal? Muy buenos días y bienvenidos. Soy la doctora Eunice Itzelva Yarteaga, médico psiquiatra y
I am Dr. Itzel Bernice, a psychiatrist. For me, it's an honor to be here with you again in the last day of the Second Congress of Mental Health. Thank you very much for your attendance. Good morning, welcome. I am Osvaldo Domínguez Calderón, clinic psychologist from Psiquiatría Morelos in Ciudad de México from the Instituto Mexicano del Seguro Social. We're going to start today our activities with the importance of mental health in the initiative Safe and Healthy Work Environments. For this topic, we're going to have the participation of Dr. Rebeca Velasco Reina, Work Health Coordinator in IMSS Mexico. She has a master's in science, security, and occupational health by the Ludwig University in Germany, specialist in work medicine by the UNAM and the Mexican Institute of Social Security, surgeon by the Medicine School by UNAM. Her current job is coordinator of work health in IMSS. She's been chief of area of surveillance of work health in affiliated companies to IMSS, medical program coordinator of work risk in work health coordination IMSS, professor of environment, work and health from the School of Medicine of UNAM. Participant of the directive board of the Mexican Council, Work AC
2012, 2014 y
2013, 2014, and 2016, and 2018.
artículos en revistas.
Author of many articles.
Buenos días a todas y a todos. No sé
Welcome.
Si
Good morning, everyone. I hope you can hear me.
Perfecto. Pues es un gusto para mí el poder estar con ustedes en este congreso.
It's a pleasure for me being here with you. First of all, I would like to thank organizers and Norma Palacios for her invitation and to be allowed to talk about workers,
Los programas que estamos realizando por parte
mental health, and all the work we've done through IMSS to promote mental health. Specifically, I'm going to talk about this strategy called Healthy and Safe Working Environments.
Gracias. Bueno, quisiera comentarles los antecedentes.
I would like to talk about the background a little bit, why we started with this strategy. It had a lot to do with the pandemic. We lived different situations because of the pandemic. We identified the need to strengthen health and security in the workplace, specifically in work centers. New ways of work like remote working, change of turns, of shifts, longer schedules, and this created certain red flags that we need to take into account for this initiative. We also had a dialogue. There was a lot of companies who had to close because there was a lot of communication between what the companies had with IMSS and workers. It was very important to have programs that promote good habits in workers. We also identified the technology as a tool to massify information so that we could all be connected and that the information presented was the same. And the central role to preserve their health. When we started the pandemic, when we saw all the risk factors or the health conditions that could predispose someone to be vulnerable to have a more severe COVID situation, we saw that at least half of the workers had a health condition that made them vulnerable. So it was important
conjunta para mejorar la salud de las personas trabajadoras.
for all of us to work together to improve their health. It is also important to mention that the WHO says that 1 million persons commit suicide each year. Every 4 persons suffer from a mental disorder throughout their life. 450 millions of people suffer a disorder or behavior, a mental or behavior disorder, and 1 of each 6 causes are related with neuropsychiatric disorder.
Internacional del Trabajo hace
From the
referencia
International Work Organization in 2016, it increased the load of sickness related to mental health problems, and this is associated to long working schedules.
más de 744,000 muertes y 23.26 millones
This
de
created more than 700 deaths and more than 23 millions of years of life adjustment. And the most common was ischemic disease. It is also important to highlight regarding the hours of working hours that we have. For example, working 56 hours or more per week, it increases the risk of heart disease, and it affects 1 in 10 people worldwide. In Mexico, we have working sickness
sociales. Nos enfocamos mucho
related to risk factors. We focus that it may create problems like anxiety, depression, and it is also important to mention that these risk factors may create heart disease and brain disease. That's why it is very important to create actions to prevent.
En general, quisiera comentarles, ustedes pueden ver en la pantalla.
Also, what you see on screen, these are recognitions of working disease from 2019, 2020, and 2021. As you can see, we've qualified with behavioral and mental disorders. This doesn't mean that there are no disease to brain or heart created by these psychosocial factors at work, but physicians don't make the relationship that the main cause of the health problem is created because of his work. Workers also don't suspect it, so that's why register is not correct. So that's why we're trying to communicate that this type of pathologies may be created because of work. Regarding this sickness that may be recognized because of risk factors, we have here their codes, the acute stress related to anxiety.
Y en este apartado también se llega a incluir lo que es la cardiopatía.
And also we include the ischemic brain disease, acid peptic disease, syndrome and irritable syndrome. Also sleep disorders like the ones on screen.
Ahora, es importante mencionar que actualmente en la tabla de
It is
enfermedades
important to mention that in this table, we only have 1 fraction to recognize this point, but as soon as the doctor can identify the cause and the effect of work and disease, they can use the 17th law of the 17th article of the work law and recognize any of the disease we just saw as a work disease. With this collaboration between IMSS and other organizations to update this table, we specify more for anxiety, depressive disorder, non-organic sleep disorder, those related to severe stress and adaptation, cerebrovascular heart disease, and irritable bowel. With all of this background, it is a priority that in IMSS, we created a strategy to prevent. We don't want workers with these health issues, so we need to create awareness of prevention to see between all of the worker groups to avoid this problem. This strategy called ELSA, it's a voluntary program.
Es gratuito.
It's free, it's voluntary, it's not punitive. This is very important to mention because when the IMSS, we want to get closer to companies and they are scared that we maybe create some repercussion to the company, the fact that they open the doors. This program is not like that. What it looks for is for us to be a tool to support them,
Diferentes herramientas que vamos a ver durante la presentación.
to show them different tools with the objective of improving their health, support them to prevent risk factors, psychosocial risk factors,
Crónico-degenerativas. También estamos muy enfocados
and chronic disease. We are also many times risk factors and mental health are associated to work accidents because of the conditions they have. They may have an accident or long working hours, etc. So that's why we need to see it globally. What this looks for is to improve the health of the people, their life quality, and this will also help companies to improve their productivity when taking care of their best asset, which are their human resources. This cannot be done unilaterally. It is very important to have the collaboration of the company, the workers, unions, and of course, IMSS. This strategy, here we can see in the screen, we have a microsite called elsa.gov.mx. You can go online. We are going to focus in point 4, which is the prevention of work diseases related with risk factors, but we invite you to check our website and the strategy, which gives a lot of important recommendations that may be useful in your own country.
Y bueno, esta línea 4 está...
This fourth line is closely related and focused to the Mexican norm 035.
Hace referencia a que los factores de riesgo
which references the psychosocial risk factors at work and defines it as those that may create anxiety, non-organic sleep disorder, severe stress disorder, and adaptation disorder that may come from the activities at the job, the working hours, the schedule, exposition to traumatic events, and also work violence, among others. This fourth line has different items, which you can see on screen, and we're going to talk about them. It is important to mention that we have these tools, and we consider they will help the employer to identify the self-diagnosis, and it's better how much they have applied the norm in their work centers. It is not a list different to the one in the guidelines. is just a self-diagnosis and will allow the employer to identify what has his company do for prevent these risk factors, prevent the risk factors, also work violence, identify and analyze these risk factors, and the negative effects.
Diagnóstico le va a permitir identificar en qué
This
punto
self-diagnose will allow them to identify where do they need to focus on. Once the employer answers this self-diagnosis, they're going to get a percentage of compliance they have in these preventive activities. There are other 4 action lines, which also include questionnaires for self-diagnosis of different norms,
que ustedes pueden ver en pantalla y que de manera automática la plataforma le permite decir el
which you can see
porcentaje.
on screen, and automatically they will throw you a percentage of compliance. This is just a guide, it's not punitive, just for them to know what they need to do. For each question of this questionnaire, we have support material that will work by physicians and engineers of work health in the country, and these will allow the employer that personally, I mean, they don't need to hire a consultant or anything. The company itself may do the modifications they need to be able to do these changes.
Complementaria en la plataforma CLIMS que pueden ver ustedes.
Also
en pantalla.
complementary, the CLIMS website, which is also free
Constancia que está disponible las 24 horas del día, los 365
and is available 24/7. And these 2 courses, the first one, the preventing working disease, lasts 3 hours and has focus on workers. This is a course that where the employer can promote among their workers guidelines that will allow them to understand the norm, why it is important to check them with the company and the union to have these preventive actions. And the other course is monitors for a safe and healthy work environment. This is for management, for the ones responsible of security at work, and it will give them the best tools of the first action lines so they can start the program in their own work centers. We also have in this platform, so the companies can go in, is open for the whole public, where you can see support material, technical information. But to start the program, they need to register. It's free. It's very simple. And in the platform, you're going to see these tools for assessment, specifically for prevention the psychosocial risks. You can download 2 files already with the formulas of Norm 35. Second, for work centers with 50 workers, or the third one, which is with for work centers with more than 50 workers, so they can fill the information. And once it is complete, they'll be able to see the results automatically, as you can see it on the screen right now. What these tools look for is for small and medium companies that don't have the economical resources to hire consultants, so they can do it on their own. They download the file, fill their information, and they can have the results immediately. Since it's a downloadable, the information will be kept at the company. During the ELSA strategy, since we talk about many topics, like the risk factors and well-being in general at workplace, sometimes the employer needs to decide where to start. It is important to invest focused. There's also a document to prioritize these expenses, and they fill the information, and depending on their answers, they add the information in this Excel document, and it's going to guide him or her to identify where's the first point they need to take actions because of the high risk, because of the serious consequences, a high number of persons exposed to that risk factor. So they need to start with that. So for decision making in the company, many times is related to management issues. So this tool is going to be very useful.
Y bueno, también es importante mencionar que
It is also important to mention that IMSS, through the worker coordinations, gives to the companies added to subscribe to this self assessment.
por vía correo electrónico.
We are going to contact them via through email to offer them also consultancy. These are done by engineers and physicians. These are optional. If the company wants our support, they will get it. They're free, and the results will not create any type of problem or a fee or something like that. It's not going to create any legal situation. These consultancies can be virtual or in person, because we know some centers are very far away, so it's hard for some consultant to go there. And sometimes it has happened with banks because of the security measures they need to have. They cannot receive persons external to the companies. And in those cases, it's been very useful to have this virtual consultancy. As a base is the answers they gave. They're gonna accompany the company with reviewing these points that they mentioned in their assessment, self-assessment. It is necessary to do some recommendations. They will be left written. And a second consultancy is offered in case the company accepts to check the final notes and to check they made some changes and do follow-up. Within the platform, we also have a board where the company can see the evolution of their needs. Depending on the sector they are, it could be general disease, maternity, or work risks. This is for the company to identify the main health issues they have, and they can focus their preventive actions. It is important to mention that this is not information is not to determine the risk, it's only informative. As a summary, what we look for with ELSA is to support companies so there's a better level of well-being in their employees and at the workplace, to reduce people not going to work because of a health issue related to the psychosocial risk factors, to improve work activity with a healthy environment, to improve the organizational environment, the healthy work relationships. If someone was to work, so they do it in a well state of health and not to affect their health, so they can do their work properly also. to strengthen good habits, and this will reduce costs related to medical care and employees' health. This could be because of non-programmed absence of workers because of their health issues. And that would be it from me. I'm here for any comments. Thank you very much. Thank you, Dr. Rebecca Velasco Reina, because of your conference with such important information and transcendent information for working environments. There were a lot of questions, however, the presentation was so informative that they were all answered, we guess. So we really thank you for your intervention, because the norm 035 has been making us work a lot in institutional environment, private practices, but having this type of knowledge and knowing that norms are just a guideline and they will take us to a better health globally, not only at work, it's more easier to apply them and follow them. So thank you very much. Thank you to you, and we invite you to the website. Thank you. Have a great day. Thank you.
Pues estamos. Excelente, pues entonces, dando continuidad al eje temático del día de hoy, que es que hemos avanzado.
Okay, continue with the topic of today, which is success cases and what we've done. Let's remember that we need trained personnel and staff, and that's why we have the next topic with a symposium. For the topic for this symposium is mental health and addictions, getting close from the training of the health staff. And we have as moderator, Yvonne Lisette Carpio Garcia. She has a master's in organizational development and talent management. She is a leader of the pedagogic group for the exam for medical residency, also coordinator of development in private initiative, in part of the internal groups of perinatology, also director of the exam for medical residencies, and she has created the model of cooperational relationships at work. And here you go, Yvonne Lisette Carpio Garcia. Thank you very much. Thank you for your presentation. Welcome to this third day of this International Congress of Mental Health. Particularly welcome to this symposium, Mental Health and Addictions, getting close from the training of the health staff. We're going to see it from different perspectives by our experts. It is important to start with an introduction of the topic that from different studies and research, it shows that there's a prevalence in addictions related for their occupations. One, for example, health caregivers. When they begin their careers, they present a more psychiatric morbidity load comparable with other working environments, and it's progressive. We've seen the determinant of their mental health, and the rates of depression and anxiety disorders increase. They use more alcohol, other psychoactive substances, food disorders, and they even have suicide attempts. many factors that affect their mental health is the academic conditions, which are very stressful, academic tests, and the example is in our careers is the national exam for residencies, high levels of responsibility while they are in internship, where the health givers are in charge of these loads, the expectations, and family expectations from the sector itself, and the self requirements also, and also the structural violence they live in these educational processes. So we're going to give continuity to this symposium. I would like to introduce one of our speakers, Dr. Milson Agustín Contreras Carreto, Director of Process Improvement in Quality Direction, and he's representing the General Director, Dr. José Luis García Ceja. To introduce Dr. Milson, he's a surgeon, theology and psychology. He's specialized in pharmacodependence issues, internal medicine, quality and statistics, human resources, and integral education of sexuality. He has a master's of prevention and treatment of addictive behavior, contemporary theology, directive abilities, and company psychology, and PhD in administration and mental health. Currently, he is from the Spanish Association of Study in Drug Dependency, the medicine school in Mexico, the Mexican Society of Public Health, Mexican School of Medic Audits and Management of Health Services, and currently he is Director of Improvement of Processes in Quality Direction. So welcome.
Adelante, Dr. Nilsson.
Muchas gracias.
Go ahead, Dr. Nilsson, please.
Licenciada, muchas gracias a todos por...
Thank you very much. Thank you very much for the invitation. I am having some problems. I'm going to try to start my video. I think that this is a very interesting topic because of the dynamic that's internationally experienced. As you very well say, structural violence in staff education during their education on their different departments related to health, social working, nursery, medicine, have been recently questioned in terms of how much is mental health affected during educational programs. First of all, I would like to emphasize that mental health is something wider and deeper than only talking about mental disorders and behavioral disorder. Mental health is a well-being condition where individuals can face their normal difficulties in life. A person is aware of their own capacities. There's a cognitive aspect to it. They can work productively, and it's able to contribute to their community. Next, please. And specifically, as the introduction mentioned, in order to address mental health in primary care, we need for our internal physicians, residents, nurses, psychologists, social workers, and others to be trained in mental health care, prevention, assurance. But this also means that we have to understand what goes on at a mental health level within this staff. I would like to emphasize that 1 out of 4 people in America suffer from a mental disorder. From 1 to 5% in most of the countries here in the American continent is only given 1 to 5% budget. And talking about mental health is more than just the mere absence of mental disorder. We are talking about a concept that's interrelated to well-being, but comprehensive well-being. A mental disorder is characterized by a clinically significant affectation, alteration of cognition, emotional regulation, or the individual's behavior. And there is a lot of stigma surrounding mental disorder and their care that will have a certain impact, as we will see on the next slide. It is important to understand what Santa Maria said in his text. In order to understand a problem, first we need to define said problem. Hence, we would have to start from the general problem, which is addiction in general population, all the way to the particular problem, which would be addictions in health workers, and concretely
en personal información y no solo
in
la siguiente, por favor.
personnel only under education and not only workers.
Enfatizar que cuando
And it is also important to emphasize that when we talk about education, staff under education, we're not only talking about physicians, but also we are talking about pre-grad students,
del mismo modo
residents, interns, as well as nursery, pre-grade, and postgraduate studies people, but it also includes psychology, nutrition, amongst others. Next, please. There was a trial published in JAMA Journal in 2016, where different researchers found that 27% of med students suffer from depression or have symptoms, and 11% of them has had suicidal thoughts during their pre-grade status. And there is a meta-analysis taking into account almost 200 studies with 129,000 med students in 47 countries. There is a greatest level of depression in women than in men, and also there's a higher score in parameters of personal disappointment, underperformance, and easily crying due to stress. Med students are 2 out of 5 times more prone to suffering from depression than general population, and its prevalence will depend on the reporting institution. However, it is reported that it varies from 9% to 56%. Next, please. Health professionals of the different areas that we've already mentioned when concluding this study have a greater rate of mental disorders compared to general population, mainly stress, depression, and burnout syndrome. Many trials have proven that professionally exercising health affects health comprehensively, both well-being and mental health of students regardless of their educational level. And this is aggravated by the stigma lying under mental health care. And for personnel, it turns out to be complicated because of discrimination that could be seen related to this topic. So it may be hard asking for help. And in many cases, suffering is hidden, stress is hidden, until it becomes disabling and fatal consequences are even developed. Next. Many factors affecting mental health of the staff under education have been detailed. First, general stress, academic workload, and exposure to sufferance and possible death of patients, as well as interaction with other medical professionals that turns violent or hierarchical, the limited or scarce interaction and social life, little time with family and partners, little time of sleep and rest, hospital responsibilities that are not prepared and well trained for, psychosocial and work risks in the area that depend on the maturity and the psychosocial risk factors in each of the institutions within the sector. Relationships that are not constant because they have to turn into a distant relationship when the training staff has to move from their cities, and patients and families complaints, and even violent actions against mental health care workers. Next, please. It is also important to highlight that there is violence during professional training of resident physicians. This slide shows a trial study that was done in 656 residents in 16 units where psychological violence, physical violence has been reported. Next, please.
¿Me escuchan?
Can you hear me?
Sí, lo escuchamos.
Yes, doctor, we hear you. We have already advanced your slides.
¿Sí se ve?
¿Listo,
Can you see that we are advancing your slides?
La lámina en pantalla.
No, no logro verla. No sé si los demás logran verla.
Oh, no, sorry, I cannot see it. But
Y,
can the rest of you see them?
En pantalla el diagnóstico dual
Yes,
en médico residente.
we have dual diagnostic in resident physicians. It's a table.
No puedo ver la,
okay.
la pantalla, pero continuamos para...
Well, I cannot see the screen, but then I can continue.
Dr. Nilsson.
Dr. Nielsen, I think we lost you. We cannot hear you anymore.
Perdón, ¿me escuchan?
Sorry, can you hear me? Yes, now we can.
Muchas gracias. ¿Podemos poner la anterior?
Yes, thank you. Sorry. Could we go back one slide, please?
En esta lámina, lo que quiero enfatizar es que también
This slide highlights that mental disorders include substance use and abuse. In this 192 resident physician sample, we were able to see in this study that most of them smoke. There is marijuana consumption in 53% of them. Most of them, up to 53%, are frequent alcohol drinkers, and mainly amongst the abused drugs, we have tranquilizers or drugs and substances. I would like to emphasize that currently it is believed, wrongfully believed, that male physicians are the ones that consume substances the most. In these cases, and in these studies, the users were women compared to men. And in terms of the experimental use, it was mainly in men, higher than, the number was higher in men than in women. Next, please. In this graph, we have different studies that have been done according to the affectation that we could see if there is substance abuse and other diagnostics, and this is called dual diagnostic. In 2020, we can see how different authors have detected and have consistently found that resident physicians are affected in their mental health, mainly with depression, anxiety, moderate, slight, or severe, some with some risk, suicidal risk. In some other, we have anxiety disorders, social phobia disorders. But out of all of these mental disorders, the most concerning is the highest rates of suicide risk. Next, please. Next, please. Sorry, I'm having problems with my internet connection. Yes, doctor, because of the problems, maybe it's easier if you turn off the camera and we can continue with the presentation. I think it will go better like that. Yes, I will. Thank you very much. Currently, we have to understand this dual pathology, which is detected using some questionnaire type of instruments and tools, in which, depending on the questionnaire, we can detect if there is any use or abuse in terms of alcohol consumption, tobacco consumption, or some other drugs or narcotics. Another element that's important to emphasize, besides structural violence, that they experience suicide risk and this excessive workload that resident physicians experience, as well as interns and nurses, is also the burnout syndrome. There are different risk factors that's important to emphasize. For example, different person or characteristics, features, and because of the academic syllabus and program, it may cause emotional stress. And there is a high expectation also that they have from themselves as well as the family members. And also previous substance use and abuse. From the work point of view, also working days are very long. The distribution of assistential workload and academic workload during the first year is, well, there's also less autonomy. We see seriously ill patients where there is no proper management, nor for this interpersonal contact and communication with family members. Also hostile work environments, but there are also some other protection factors that we need to emphasize so that they can be reinforced, as well, such as empathy, emotional management, the time with their families and their partners, entertainment times, hobbies, social supports, the use of networks, improving education, compensations, plans, etc. Next, please. And so, another element that I would like to emphasize is that all of these stressors that we normally see in staff under training were aggravated during the COVID-19 pandemic. There were schedule changes, suppression of holidays, they had to be sent to other services, and we even had surgical departments seeing people with COVID that were seriously ill. So the negative impact in the clinical or surgical experience was affected, as well as the concern for keeping the skills of the specialty in the 2 years that we've had to reorient efforts towards only one pathology and its consequences, which is COVID-19. Next, please. There's also been, within the experience, health institutions that have been addressing mental health and its importance. There are different institutions such as the National Institute of Psychiatrics and the Mexican Institute of Social Security, and some programs of the Ministry of Health, just to mention some of the most successful ones, where we have established certain specific departments for the attention of mental.
Y esto se vuelve particularmente
And this
importante
becomes particularly important in the current context because all of these mental disorders that were currently seen pre-pandemic and were already identified have been increased in the post-pandemic stages, and that they are quite similar, such as depressive disorders, anxiety disorders, and that we've seen globally, as you can see on the graph. We have a variation percentage of up to 27%.
y trastornos de ansiedad.
Sorry, doctor, you have 3 minutes left. Next, please.
Es importante también dentro
It is also important to include not only health institutions in this process, but also reinforce the activities with colleges. Next, please.
Pues hay muchas,
And at the Ministry of Health, there are different initiatives to address different aspects of mental health, among them the training personnel on violence, addictions, as well as the main mental disorders in order to address this specifically vulnerable population, which is the health services interns. To conclude, medical training is notoriously stressing and competitive because of the environment where they live. They need many hours of study with very few hours of rest, and there are other factors that contribute them to be in the highest rates of depression, including stigma against seeking attention or care in mental health and constraints. So we need to strengthen public policies in an efficient way to address the topic in benefit of the training staff. That'll be all on my part. Thank you so much, and I'm sorry for my internet connection problems. Apologize. Thank you so much, Dr. Nielsen, for your participation. So the important takeaway will be going over addiction prevalence in women and to do gender care for women in health services. We will continue with our symposium with Dr. Berenice Perez Ramirez. She is a coordinator of the Center on Disability Studies at UNAM. Welcome, doctor.
Pues primero agradecer a todas las entidades convocantes.
First of all, I would like to thank all of the organizing team and everyone for participating. So I am going to present, next one please. I am going to present challenges in health personnel training in surrounding their mental health and the use and abuse of substances. Now I will do a very brief summary on how we reached mental health definitions. I find it quite relevant for us to have some elements, historical elements, because this also allows us to position ourselves
Los enfoques que existen actualmente para el abordaje de la salud mental. Después me centraré desde qué enfoque.
To address mental health. And we will also discuss what is the focus that I am addressing, as well as some of the challenges. I will be listing some of the important challenges. Many of them agree with what Dr. Nilsson already mentioned. Next, please. Well, we know that between centuries 15 and 18, craziness produced fascination in arts, literature, but it also generated fear. Fear because it was considered that this was an effect of supernatural forces, and this was a fertile field for medical ideas. During the 18th century, the consumption society was created. Market and trade grew rapidly, and it was recognized what Skoll called the structural leveraging of the new trade with dementia. And it opened possibilities for an informal network of new asylums that provided security and isolation for those people considered to be crazy. And it also turned into places in order to make a living from different professionals. In the 19th century, ideas relating craziness as a condition affecting society, they decided that life became complex and anti-natural. And I think that this idea has gained more strength facing an accelerated life where we are demanded of high standards of productivity. So we know that mental health is affected in this type of context. In this same century, 19th century, asylums were created as an answer to the psychiatric places, and there's also an anti-natural way to treat mental health, and asylums addressed mainly low-income families and members. At the beginning of the 20th century in Germany, saw a very important trend to go over the biological roots of insanity in order to find its etiology. It is important to mention that in this century, the terms that were used as lunatics and crazy were questioned. In the US, it was changed to mentally sick people, and in 1950, lunatic was replaced by mentally insane people, and they were not called alienated in France, and they were called mentally sick people. So there was a huge change in the way to call them, so that the stigma could little by little change in order to turn it into a mental disease. At the midst of the 20th century, asylums were a constant throughout the world. But sometime later, in mid-1950s, we would see the opposite trend, which is closing asylums worldwide, and this was accelerated in the decade of the 60s. In this same time, there is a huge boom to anti-psychiatrics by Goldman Sachs and Lane. These are authors that positioned themselves from a different perspective and that will question asylum. Next, please. For the Mexico's case, Rios Molina confirmed that psychiatric power was not exercised from an asylum, but outside of it via mental hygiene. And mental hygiene was a national project, a very important one that had a boom in between 1934 and 1950 in Mexico. And the objectives of this line of action were eliminating people that eliminating the idea of an abnormal or psychotic people, alcoholic people or toxicomaniac people. And this is where we can also see that in the concept of mental health, we start having a view that's focused to substance abuse. Drug consumption was a problem that as of 2020 in Mexico invited the interest of judicial, health, and psychiatric authorities because it was considered that use and abuse of substances may caused crime commission, and it was quite related to insanity. As of 1950, Mexico started developing mental health as an idea over the mental hygiene concept. So Rios Molina very clearly showed how in 1 year, they stopped talking about mental hygiene to talk about mental health. Now, the change of concept meant a model based on prevention, which is mental hygiene, to another one, which priority was the efficient care of mental health, adding neurosciences as a story. The WHO set the pace for this global change. So it was priority for the states, particularly the health sector, to be in charge of mental health care. And this aspect is fundamental because it is the one that brought us to think about this type of congresses where we already undertake that the state and the health sector has a main role in mental health and in this interrelationship with the use of substances. It is well known that the biomedical model of care has historically focused on mental health from an individual perspective, based in the identification of a psychopathological diagnosis. This field then turns out to be problematic in mental health since it has been limited to epidemiology and clinic, in psychiatric epidemiology and clinic, always going over the definition of mental disorders only. There are different perspectives, as the slide shows, different focuses to approach mental health. And I find it very important to recognize subjective experience of the disease and the importance of the socio-historical and cultural background where it develops. So it is important to account for the approach in terms of what used to be insanity and now mental health. So next one, please. In this sense, we summed up to what many authors explained, a comprehensive perspective of health where we include categories that allow to build complex and comprehensive visions and points of view so that human suffering with this subjective experience has to be interrelated, which I found fundamental, which is omitted in attention and care plans. That's why there is a subjective suffering idea in order to recover the psychic suffering.
Lanzar la pregunta, una pregunta mucho más.
Here, what we want to do is to have a deeper question about how the different subjects and different human groups go through life and how we recognize these dimensions, even economically, historically, socially, and culturally of our own mental health as a complex phenomenon and intersubjective, and not reduce it to a psychopathology. Now I'm gonna talk about the challenges in the training of the staff regarding mental health and the use of substances. The first one is to focus our approaches constantly. Even we believe that we get rid of old stigmas, we really require to reformulate what do we understand by mental health and what do we look for with our interventions to disappear the institution of a madhouse. It's fundamental to try to have ambulatory therapy and to recover the role of the users as subjects of rights, to understand all the network, the biosociocultural, and it's really complex to understand how this network creates in singular context until go on the bio part, the psycho part, the social part, and the cultural part in a determined context. For example, in the cases I've worked in prisons, They play a very different role when we talk in a communitary context or a university context. I agree with Stalkiner, who affirms that the exit of mental health would be its disappearance as field to diffuse in many other integral treatments that take into account these other factors of health and sickness. And she adds another element which I think is fundamental for mental health, which is care. We need to name it in these new guidelines of mental health. Regarding the use of substances, a first effort is to move it from a moral issue to what it really is, which is a public health and politic problem, to remove the punitive and the penal and go to the health. Know that working with this population is hard because they are hard to manage, because as my colleague mentioned, there are a lot of sectors in the population who are substance users. Some of them are problematic, some of them are not. So we need to stop to generalize this population because this may affect our relationship with that population. There are knowledges in very parts of the world based on evidence, which makes us realize how the focus of damage reducing is very useful. A challenge is to think in actions for reducing damages adapted to the user's needs and our expectation as professionals based in scientific knowledge. I think that's fundamental. We need to link the focus, the approach of damage decrease with this new focus of pleasure that goes together with damage reduction. To include the notion of pleasure informs us that what makes the users to use certain programs for damage reducement, and what can be the innovations to respond to these social sanitary needs. To focus in the damages because of the usually problematic use of substances has made us reinforce the strategies, but to incorporate the pleasure notion allowed us to go deeper in the positive experience of consumption and what is attractive to those to use determined programs of damage reducement. Without these methods, the reduction strategies will still be in best of cases short or even insufficient. This aspect needs to be taken into account to be seen in a micro level and also macro level, communitary actions for damage reduction adapted to the social sanitary needs of the users. Another challenge is to modify the existing practices. For example, to think about the possibility on how the health caregivers can incentive the right of being a company that breaks with this hierarchy of our interventions, to accompany them to make their own decisions, to have their clinic history, to receive correct information, so they are not individuals of research without their consentment, to give compensations when they do. I think as health staff, we should consider this, and we would wish the same things as if we were research studies. Also, in the health staff, we need to recognize ourselves as intervention subjects. For example, when we feel overwhelmed by the experience shared with us, when it's not possible to leave the work matters at work, or when in our personal life things are not doing good and we take them to work, when we perceive that we don't have all the necessary tools to take complex cases, when we feel frustrations if we don't see the answers that we expect from users. So in front of these, which are constant matters, that were more acute during the pandemic, and we know that these type of matters are acute in night shifts or long shifts. So we need to know the importance of looking for therapeutic places, looking for help, and thinking like a common practice. Finally, to assume that the professionals have a star role, being in charge in identify, diagnose, intervene, or channel the cases, we need to look at better training in managing this. It is important as finding more budget from the state for this type of projects. Also, that the mental health care in Mexico shouldn't be specialized in the third level, but we need to think in other levels, like in first level, nor reduce the services to psychosomatic symptoms, because this makes them harder to be treated and diagnosed. Also, we need to have collaborative work from first level workers and specialists. Thank you very much. And I'm here for any comments. Thank you. Thank you very much, Dr. Berenice Perez. Thank you for your intervention. Without a doubt, we first need to change language, because language transforms reality. Also, the integral approach that you mentioned that we need to have for seeing mental health, not only the biomedical focus, but and the physical parts. Also, it is important to highlight the using pleasure to make those behavioral changes so that the behavior changes positively if it needs to change. Thank you very much, Dr. Berenice. Now we're going to continue with this symposium with Dr. Graciela Polanco Hernandez. She comes from the psychology programs. She has a master's and PhD by the psychology school in UNAM. She has a specialist in psychotherapy from the military hospital. She had a grant by the Mexican government in CONACYT. She had a research internship in Oxford, and she's been academic full-time in the psychology department of the Iberoamericana University in Mexico. She's professor in psychology and psychology research. She is author of many articles, and she has received many recognitions. One of them, the diploma in 2020. She's in charge of the development of academic program of psychology emergencies, and her work is focused in mental health, psychosocial interventions in urgencies. Welcome, doctor. The floor is yours. Thank you very much. Thank you for inviting me to this forum with so much participants, more than 3,000 participants. It's a pleasure to be here. I greet all of you and all the organizers of the event. So they told me the importance about talking, creating a dialogue about mental health within the medical staff, and that it should be included in their trainings. I would like to talk again about a definition that we have from PAHO about the training. I'm going to read it as such. The training of human resources should be as an answer of the national demands, especially regarding emergencies and disasters. This definition talks about question ourselves, what have we done to face these emergencies, and that we live in an emergency state. However, we are coming out, or we are in the last part, I hope, of a period that modified the behavior of the world, COVID pandemic. What have we done about this? We've given answers to this. I would like to mention that we've linked, and I celebrate this link between universities and health organizations. By request of a health secretary, we started a course about COVID and mental health for mental health professionals working with children and teens. It was an online course where we had a participation of more than 2,000 persons, medical staff professionals, mainly psychologists, physicians, and social workers, linked to the work and psychosocial interventions with children during this health period. This was an online course. It was in the Iberoamerica platform, and it was free. So we could start with this specific training for addressing psychosocial emergencies, and it was a success. We continue with this training, also done with the health secretary in Mexico City, where we linked also with the Iberoamerican University in Mexico City in the platform. Sorry for the interruption. If you could change the visibility of your presentation, please.
Arriba de su lámina es la segunda pestaña del extremo superior izquierdo.
¿Izquierdo?
Sí, arriba de su lámina.
No. A ver, dejo de compartir si quiere y me dicen. A ver, de compartir y... ¿Qué no se ve o cuál es el...?
Ahí nada más, por favor, en pantalla completa, por favor. Ahí estamos.
Todo bien.
¿No se ve?
Otra vez ahí, por favor.
F5. No le pueden hacer como allá.
¿Qué es lo que sucede?
No se ve en pantalla, doctora. Completa.
Mira, pongo en pantalla completa en su computadora.
¿Ya?
Sí, y que la
Ok, sí, me comenta que así está bien y nada más la va pasando por el lado de la columna izquierda, por favor.
¿Ahí no se veía o qué?
Sí, teníamos problemas en la visualización, pero puede continuar y le vamos informando, por favor.
Ok, entonces... ahí se ve donde están las dos imágenes oscuras.
Can you see the both dark images? Yes. Okay, so in February 2021, we had this course with the health secretary, the Psychiatry Institute, and G. González Hospital, where we had a lot of professionals, experts in mental health participated. It was a course directed to medical staff to give care, to address self-care. It wasn't about knowledge. It was for them to have information about self-care regarding health care in medical staff during the pandemic. Something very interesting and requested to know a little bit more, and not only being this course about self-care, but to know how the staff was before the course and during the pandemic. We did a filtering and assessment, and this assessment, we had the participation of those who were going to take the course before it started. They received the request and to be part of it. Once they gave the consentment, they would see a screen where they would answer a survey. What we assessed, the objective was the levels of occupational burnout, the stress, anxiety, depression variables because of COVID that we were living in the pandemic, and also risk and protection factors of mental health in the professionals of medical caregivers. We had 3,856 workers, all of them affiliated to the different public organisms of the public health secretary, and they participated voluntarily. Here we see the details: 270 now, 53% give clinical and medical intervention, 1,081 administrative, 627 general services, and 69 clinical and lab analysts. These 72% women, 25% men, between the ages of 20 and 66 years old. During the filtering, 4 instruments, standardized instruments were applied. One of them was the Mexican burnout scale, depression scale, self-efficiency index, and identification of abuse of substances. This was before they took the course, the online course of self-care. So we didn't have the variable of being linked with the information that we were going to give. And we found out that just one of the 3 components of burnout components, which is depersonalization, became positive to alcohol consumption. Burnout syndrome, like fatigue, depersonalization, negativity, and self-efficiency, reduce of self-efficiency, is an answer to stress that workers present no matter where they work. Emotional tiredness and insatisfaction had no significant effect with alcohol consumption, and auto-efficiency acts as a mediator between burnout, depression, and the use of alcohol, which is the disruptive use of alcohol, which increases when experimenting depression and burnout. So what we need to consider with this information, that substantial changes on how they work changed during the pandemic. We all know it without the study, and that it put them in an extreme situation. The obligation of being in shifts of 24 hours, it allows them to not sleep well, and having possible making possible mistakes because of burnout. In some studies, we found that it is possible to improve partially the personal burnout through self-care tools, with an improvement in work conditions and environment. It is important to have present that these results were during the pandemic, in a critical period where the health staff were really losing symbolically and real, which tended more to take them to alcohol consumption to alleviate the pain of depression. And with this emotional pain because of the passing away of colleagues, families, friends, and the frustration of not being able to avoid this. It is also important to say that with the knowledge left by the pandemic and these type of studies about mental health during the pandemic, during emergency periods, it's important to apply them to the work environment, training, and their shifts. And it is a way how the pandemic has faced us through many challenges, and we need to give answer to the training and self-care, and also to link all health institutions with universities to create programs for interventions and research. These data you see were taken from this study. Here are my references, and hopefully would be published soon. And to finish, I would like to thank that for the taking care of this study. We had the opportunity of working with the Direction of Training and Update of the Secretary of Health, and also with the National Union of Social Security. Thank you. Thank you, Dr. Graciela Polanco. Without a doubt, COVID has made the evidence the needs of training and the care of the medical staff. However, we are still have a long path to walk, and we need to do it interinstitutionally. Let's continue with the symposium with Dr. Marta Georgina Ochoa Madrigal. She has a master's in medical science by Anáhuac University. She has a master's in medical science with a specialty in psychiatry by the Mexican Institute of Psychiatry. She's a specialist in psychiatry with a subspecialty in child psychiatry and teen psychiatry by UNAM and Centro Médico. She was an academic in the School of Medicine in UNAM, pre-certified by the Council of Psychiatry, ex-president of the Medical Society, attached physician to 20 de Noviembre Psychiatry Service and Neuropsychology, chief of postgraduate of in the same hospital. She's also chief of psychiatry service in neuropsychology and psychology of 20 de Noviembre Hospital. Thank you very much and welcome, Dr. Marta. Thank you for your invitation, and thank you to all those people online. For me, it's an honor to be in this second Congress with a kind of a hard topic, because we need to talk about all of this. This problem started since, let me check my presentation. Can I share them so I can change my slides, please?
No me da acceso a modo presentación, Emma.
I cannot share my presentation.
¿Me pueden dar acceso?
Sí tiene acceso, doctora.
Ok, porque no me da modo presentación. Compartir.
Compartir. Abajo, en el extremo inferior izquierdo, donde dice compartir pantalla.
Aquí. Un momentito, vamos a estar.
Just give me 1 second to open my presentation.
Sí, está un poco lenta, doctora.
Ok. Si quieren, empezamos. Vamos a
Okay,
hablar
I'll start in the meantime. We're going to talk about this approach in terms of the general to the particular. I am interested in knowing what's happening in the population in general, specifically with how this problem is created, addictions in the general population, specifically in teens. Somehow, this is the population where we see most impact. And as this slide shows, I don't know if you can see it. It's loading. Well, the impact it has, drugs on general health. Let's not talk about mental health, but the health in general in the population, it's very important because
Doctora, me comentan que si gusta la podemos...
Doctor, we can share your presentation so it's easier for you.
Doctora.
Creo que es su red. ¿Les parece bien si continuamos y al final?
Let's continue and we leave the doctor at the end.
Adelante, licenciada.
Okay, go ahead.
Vamos a continuar y vamos a dar oportunidad a que la doctora Graciela pueda.
Okay, so let's continue while Dr. Graciela can fix her internet issues. The next presentation will be by Dr. Sandra Beatriz González Mota. She has a master's in educational sciences. She is a coordinator of nursery programs, and she has a technical department at IMSS. She is a teacher in thesis projects in Universidad Cuauhtémoc in Aguascalientes branch. She has a degree in nursery by the Autonomous University of Aguascalientes. She has a master's in educational sciences. She has a postgraduate studies in nursery. And he has other postgraduate studies in person.
Ella es
related
calificada en la carrera institucional docente.
She is certified by the Teaching Institutional Career. She has 32 years of experience in nursery human resources activities. And she has published research articles at an international level. She is representing Fabiana Maribel Cepeda. Please go ahead.
Bienvenida.
Buenos días a todos. Muchas gracias.
Good morning, everyone. Thank you so much for the kind invitation and for considering the IMSS Technical Nursing Department. On behalf of Fabiana Maribel Cepeda, I would like to thank the organizing committee, Dr. Palacios, that's part of a strategic group in mental health here at the IMSS. So I would like to start. A lot has already been said on the alterations in mental health in the training mental health staff. So I will be talking about nursing department. It is quite gratifying to see how this profession has been evolving in a positive way, as well as its concept, because the concept is not mental disease anymore, but what are we doing to preserve mental health? which is the challenge and not the goal, and especially to increase the coverage, since professionals that are trained in mental health care find it very hard to cover this problem, which is visualized
Si me pasan por favor
regardless it having existed for so many years.
Denos unos segunditos y
Just give us a couple of seconds, please, to start sharing your screen.
Y bueno, con gran satisfacción les comentamos mientras se...
And with satisfaction, I will share that the IMSS has focused in training nursing department in first level care in order to timely start with detection in people that are apparently healthy in their mental health. But we have developed at Prevenims different mental disorders detection, panic attacks, anxiety, depression, etc. This intervention is carried out through the application of a THQP questionnaire plus THQTP that's applied of everyone older than 20 years of age that go to Prevenims units at the first level. In order to start this presentation, I would like to tell you that nursing professionals work constantly 24/7 throughout the hospitals. And for many years, we've been working in creating theoretical and methodological principles to be able to clearly confirm that nursing is a science. Now, with a new focus and with the need to provide a focus on comprehensive care. And with this, we are impacting in mental health and in training in order to provide a professional-based care. Now, relating this with art, the nursing efforts go to an upper level. The critical thinking becomes critical without leaving behind human being approach when they need a professional care and to provide a dignified care as the WHO states. For this, the scientific preparation becomes critical as well as continuous education in these departments. Next, please.
Más cercana a lo que es enfermería y salud mental, bueno, pues enfermería es una disciplina.
Mental health and nursing. Nursing is a discipline that's an important part of mental health team, not only within institutions, but also in community health teams, and in all of those roles and network and care teams that have been created to provide services and care to this problem. Theories and knowledge on the care of others has been provided. There is an intervention model that currently considers the condition of transition, since we have had to reset and reconfigure due to the new demands of care. And this is why at the Mexican Institute of Social Security, IMSS, nursing department has received continuous education and training when doing mental health screening. The specialist is trained to provide care during the different stages of the life of the person, children, teenager, so they can further be referred to their family physicians that are also trained to address these psychiatric alterations. There are some diseases that affect people's mental health, And there are also other mental disorders that are already described. It includes also populational aging, and we have to be prepared to provide attention in a comprehensive and professional way. All of these changes in social and individual roles are of utmost importance for nursing department, not only in the individual and family levels, but also it is necessary to approximate to share social responsibility and community participation to address these topics and reach the goals. These are some main concepts on what mental health nursing is. It is important to highlight that we don't have any specialization in colleges. Very few of them offer specializing in mental health nursing. In such a way, it is necessary that non-specialized staff to receive proper training to address this problem. One of the concepts on mental health nursing states that it includes human behavior to prevent or to fix their behavior to prevent further problems on themselves or the community. The best way to prevent mental disorders is intervening people that are apparently healthy. Another concept that we have on mental health and psychiatric nursing reads, it is a specialty of health and anthropological sciences that studies not only biological causalities, but also psychological, psychodynamic, and sociocultural conditioning motivations of the mental disorder and in its different forms, applying the proper care and attention. So it is important to know all of this scientific evidence to provide comprehensive care and a care that's addressing alterations that are specifically emerging in community or in hospital settings. Next, please. Another concept that we have in community mental health nursing, since we're already talking about community states, that it is interrelated to the compression of social processes, political, economic, scientific, organizational, family. The social context has been modified for the last year. So we are subject to many pressures, not only in the work and family and social environment, but as well as others. All of this affects mental health and psychic suffering. This branch of nursing is a main axis. So caring for the other is done as of human, social, and family concepts. All of this is theoretically based and evidence so that nursing staff gets prepared to provide care and attention to this type of problem. The concept that PAHO shares on community health nursing states, it is a system approach. It mentions the importance of distributive nursing practice, which is conceived as providing care to risk population within a context of their significant social networks. So this practice includes community mental health without excluding primary care. So in our program, Prevenir, we are including mental health not only as a health promotion problem, but as a risk detection in order to provide timely care, and to prevent sequelae or disabilities. Next, please. These are some data addressed by Bedoya. In Latin America, most of nursing professionals, the specialized one, works in psychiatric hospitals, as we will see later on. In other countries, such as European countries, it's important to find a greater percentage of nurses specialized in mental health doing work in communities. So there is a huge gap between concept proposals and policies founding a mental health community. So there is a paradigm transition needed. It is important for nursing as an important part of this transdisciplinary care team of mental health to be located in those community settings or in those primary care settings in such a way that we provide timely care and attention to prevent complications. Once it is timely detected and treatment is implemented, when there's a person with a mental health disorder, and if psychoeducational efforts are applied so that this person preserves their mental health, then nursing will promote all of these changes when creating alliances and recognizing problems in mental health, including all of these emerging problems that we've already talked about throughout this Congress, as well as the policies in our country. Updated knowledge and services that should be set up in the field of this psychic suffering that humankind is facing has to be addressed. This is a table where we have the staff specialized in mental health nursing at the IMSS. We only have 4 hospital medical units that are specialized. This is why we should expand care coverage. And at the psychiatric hospital number 22 of Nuevo León, we have 12 approved positions for specialized staff in mental health. All of these are occupied. We don't have personnel trained at 100%. However, the coverage is achieved with temporary positions. At Morelos Hospital, we have 9 positions for people specialized in nursing. In Tobar Acosta Hospital, we have 14 authorized positions, and in the UMF Psychiatric Hospital, we have 11. So this gives a total of 46 positions. This shows a reality that in terms of mental health, it's specialized. And however, our structure is lacking. In this sense, we deployed mental health screening in more than 20 family medicine units. Training to the nursing staff was provided, as well as public health and specialists in family care to provide and expand care from non-specialized personnel. Next, please. Also, we have a history of nursing at the IMSS. This has a post-technical certification in mental health nursing. We are one of the very few that offers this with the support of UNAM, which is one of the very few universities that offers specializing in mental health nursing. In 1988, we had 17 graduates and so on and so forth. As of 1992, we hadn't had this mental health nursing training. And today we have 158 graduates, but with combinations and dynamic of human rights in institutions, we don't have that much trained staff. After 20 years, this year, 2022, once again, the post-technical training course in mental health nursing was offered with 15 graduates, most from the state of Nuevo León, because we have a psychiatric hospital there. And positions, as we saw, are located in specialty hospitals in psychiatric care. Next, please.
En el instituto se han implementado, obviamente.
At the institute, of course, strategies to train non-specialized staff have been implemented. Postgraduate studies was done in a specialization on identification, assessment, and intervention of suicidal behavior. We had at the hospital people enrolled to be provided special training on suicidal behavior. We are continuously providing training courses so that the nursing staff receives training in brief strategies, and even the AMH-CAP training course was adapted for nursing departments so that they can have access to information so that the personnel receives training to provide care to these people and to timely detect any mental health alteration to carry out the right and proper interventions.
Para ir concluyendo, bueno, la OPS
To conclude, PAHO provided some suggestions and recommendations to improve nursing care in mental health settings. Services must be based in competency. Fundamental competencies and particular competencies must be defined for all mental health services providers. It is very important and necessary to provide professional neutrality. This means the need to offer programs, training programs in mental health competencies throughout health providers, so that not only professionals specialized in mental health receive training in order not to perpetuate the lack of interdisciplinarity.
Todo esto, información debe estar basada en evidencia.
All of this information needs to be evidence-based, as its name indicates. It means that knowledge shared has to be based in scientific evidence as well as the practice resulting therein.
La siguiente, por favor.
Next, please.
La anterior, por favor.
No, the previous one, please.
Para ir concluyendo, la integración de todos
And the integration of all of these existing systems. Educational programs have to be adjusted to systems to address these issues so that the health provider, when exercising its activities, feels that they are part of the system and that they have the possibility to adapt to the changes that are generated.
La formación de los derechos humanos de los pacientes y de las personas que estén.
Also, promoting equity and accessibility. Education and training courses needs to be sustainable. All of this allows for the development of the system capacity. Programs should be oriented in such a way that all health providers can improve the capacity of the system, the possibility to offer the right care. That's all on my part. Thank you so much for your attention, and I will be here for any question that may arise. Thank you very much, Sandra. Thank you very much for your intervention. Now we're going to close this symposium with Dr. Marta Georgina Chao Madrigal. Once again, thank you very much for the invitation. As you all know, in these presentations, online presentations, there are always technical difficulties. So I'm going to share my screen. And let's start with our presentation, which is on addictions. So I am fortunate to belong to the ISSSTE, which is a Social Security for government workers, and physicians come to us to get training in psychiatrics. So drugs are going to impact throughout the different fields: economic and social development, health care costs, as well as illnesses throughout health, both mental and physical. So this type of situations allow us to have a consumption. And all of these cause or result in a consumption. So it is very well known that tobacco smoke could cause different types of cancers, besides other inhaled drugs could damage the brain neurons. When surveys and polls are applied to teenagers to research why they started abusing and using drugs in the first place, 55% of them responded that it was due to peer pressure, that they wanted to be accepted and popular. This is also known by drug dealers, so they take advantage of this. It is important to mention that some time ago, we had some problems at schools with new drugs such as methamphetamines. These are designed drugs that tend to cause a very fast addiction. So the drug dealers know and they are betting on it with teenagers. So it is very important to act before an addiction exists. And Dr. Nora D. Volkov states that teenager years are a key window for substance use and abuse, as well as the disorder development for this use and abuse. Brain systems that rule emotions and the seek for gratifications are fully developed in this moment. However, the circuitry ruling judgment and self-inhibition are still maturing. So there is a need to develop, but the judgment is not fully developed yet, only the need of experiencing. So it is important to know that when you start abusing substances, it's in this stage of the development in life. So 10% of teenagers need a treatment due to this disorder. So it is important to know what programs exist around the world. She talks about this type of programs at a mental health services level, medical services, educational services, also HIV/AIDS services, which are secondary infections, secondary to use and abuse of substance. It is important because in the US, this is very well structured. However, another approach that we are given in Mexico is being what Medina Mora tells us, that teenagers, once again, are a special risk, and that 65% of drug users start before they turn 17 years old. Generally, it happens in an average of 25 years of age. Alcohol in Mexico represents a public health problem in the country. So it is important to highlight that normally this starts during teenager years, but abuse concludes in adult life. So what happens with the work areas? What has been seen in work areas? Well, it's been seen that there is an absenteeism that's 2 to 3 times greater among those abusing from drugs and alcohol than the rest of the employees. So all of us in an institution know that almost 10% of these of work-related accidents are due to these people going to work under the influence. So this prevention area that will be fully developed later on is very important in work centers. Now, the National Commission of Work Safety and Hygiene already talks about it. 10% of deadly accidents, of lethal accidents in the workplace are related to drug and alcohol consumption. What is the residents' approach? Well, there is a lot of information related to substance consumption. There are different methodologies and designs. However, these populations are in the dark. Pre-grade and resident trained physicians are in this situation, in this limbo where we haven't still not consolidated a relationship between this and drug abuse. So the main approaches that we have between residents and ourselves is the relationship between the consumer and the activity that they carry out. For For example, we have departments such as anesthesiology that has fentanyl at their disposal, and we've seen in our residents an abuse of this substance, and we've had exceptional cases where we have to treat them due to this fentanyl abuse. 2 minutes left, doctor. We've already talked about they being more prone to depression and anxiety. That has already been addressed. But what do we do at the ISSSTE? It has 6.7 million account holders. And we have these clinics for to stop smoking. And we have emphasized on a purple code, which is a comprehensive management of mental health emergencies that includes first level, second level, and the third level of care, where we already have beds for patient care, patients that show psychiatric emergencies. In this sense, we as human resources educators, what we do is train residents. Almost all of us receive the training course on MHGAP, almost all residents and enrolled staff. We also have discussions and presentations for Alcoholic Anonymous support. And what we've been doing at the Medical Center 20 de Noviembre is betting on the re-empowerment of our residents. We have these postgraduate programs. We do a specialized selection of candidates for psychiatric departments, and residents themselves receive this emergency care training for Purple Code. Here you see them in Tláhuac, receiving a training course on how to manage and handle an aggressive patient. And we also support residents so that they publish. We have a book and several international publications in the participation of residents, physicians. This empowerment reaches a degree where they actively participate in a substance abuse mental disorders, so they learn how to treat these problems, these diseases. So the question is the substance consumption ethical by trained physicians in order to be good doctors? The question comes with Aristotle, talking about ethics and virtues. That's focusing the character of moral people more than in the rightfulness of the action. And we are betting on residents with sports actions. These are the residents, as well as with actions so that they can participate in entertaining activities, such as going to a soccer match.
So we are looking more for prevention, to have the integration of these service in the general services, and also to talk about this with authorities and employers. And finally, we reflect the commitment that the institutes and the workers need to fight against the threats against health. Thank you very much. And I don't know if there are any questions. Thank you, Dr. Marta Georgina. We're going to go with the questions. Is there any prototype for pre-graduate students and also in the residencies? And if the immediate bosses don't attend their emergencies, who can they go with? We have a system with an ad grid which creates value groups. And these are those cases that require a BOBNOB or any issues. So there's a clinical for resident physicians. And since we're a school hospital, what we do is to also attend pre-graduate students when we detect an emotional problem. I think there are different institutions like these school hospitals, they have specific areas where they can go to their psychologist departments. And let's remember that some of them, they add in the care services because of their grants. And on the other hand, they are also part of the university. So this synergy may be useful so they can search support in either one of them.
De acuerdo. Voy con una más.
Okay, one more question. Which actions do you propose from your competence sector and interinstitutionally to implement an improvement in mental health of all health givers? In my last proposal is to have this moral code of virtues, and this is to take care of the resident physicians, giving them an area where they can express calmly, safely, and work with them so they can take courses to specialize through the vision they have about seeing patients in critic states and other very interesting protocols that I don't have time to comment on them.
De acuerdo. Hay comentarios, dice la sobrecarga.
There are comments. The overload of work in hospital units are a constant, and I don't see any programs to attend burnout syndrome.
Otro.
As I mentioned, we've treated that in cases of specific groups that are detected in different areas. For example, right now we have in treatment intensive therapy groups, internal medicine, and other group to treat them. And we have scales to detect burnout and the risk of suffering it. And based on that, the physician who takes care of them work its strengths and weaknesses by groups. I would like to mention something about the study. It was a direct request by the Secretary of Health of Mexico City to the Iberoamericana University, where we presented this course of mental health for medical staff. However, in this filtering that I showed you and I presented the results, at the end, after answering the surveys, there was a feedback to the participant where if we detected high ratings or scores, we invited them to go to and seek psychological support, and they were channeled selectively to those that had a bigger risk of issues with their mental health, high rates of risk of alcohol consumption and burnout. So there is a link between the institutions and universities. Also, if I can, I think that the Psychiatry National Institute also has a program for residents, a mental health program for residents. All staff who is in training, not only high professionals, and this program goes through the assessment throughout therapy.
De acuerdo, muchas gracias. Doctora Berenice.
Thank you, Dr. Berenice. Well, just to insist in the importance of their interinstitutionality, we have the research center, and from there we've worked on the psychosocial effects in social workers in the health sector. So there's also that possibility for any interest of linking and working not only with social workers, but also with all the medical staff.
De acuerdo, muchas gracias. Una más son
Thank you very much. Which actions are you doing regarding the professors in charge of trainings?
Bueno, desde la UNAM hay
From UNAM, there are many programs regarding mental health. The unit for persons with disabilities, we have the Mental Health Institute. We have the Research Center in Disabilities and Health. I think there's still a lot still to recognize, as I was mentioning, as intervention subjects. I think that sometimes we think for other populations we work with, but I think it's important to assume that all of us happen through different complicated processes. But the pandemic, I think, was a very important event that made us realize that everyone goes through losses. And I believe we're in a moment when we're still having anxiety because of it. And we need to be warned that nobody is safe from this suggestive problem, and we need to think in collective actions, ambulatory actions. I think it's very important to highlight this type of actions.
De acuerdo, muchas gracias.
Thank you very much. Without a doubt, there are some actions carried on right now, but there are still many big challenges and issues to address. But without a doubt, if we coordinate interinstitutionally, we can improve the results. Just to point out, I think the document that Dr. Nielsen mentioned was the early detection program and care of mental health for residents and medical students. And this is by the Subsecretary for Prevention of Health. This is available on the internet. Thank you. We're going to finish with this symposium. Thank you to all experts of this table. I don't know if coordinators have any comments. No, we will continue in a few moments. Just thank you for the invitation. And we're here at the 20 de Noviembre Hospital. Thank you to everyone for the invitation. Thank you, Mrs. Carpio, and thank you to organizers and institutions.
Gracias. Terminando el simposio.
Thank you. Thank you for your participation in this symposium in the different action lines regarding mental health and addictions. Thank you, Yvonne Lisette Carpio, for your moderation in this symposium, and we'll continue.
Son aquellos que por sus condiciones no ostentan una capacidad de
Because
resistencia.
of the condition, they don't have a resistance capability or limited capability to adapt to the circumstances where their adaptive capabilities is put to work. Also, they need additional effort to incorporate to development and relationships. So their attention needs to be a priority. Now we have the panel of mental health and addictions in vulnerable groups. We have as moderator, Dr. José Alberto Telles Martinez. He has a PhD in medical sciences, a master's in medical sciences in genomics and early dementia, also with high specialty in genomic medicine and cognitive aging. He is member of the International Association of Parkinson and Movement Disorders. He's also member of Alzheimer Association, Research and Treatment, and he's currently Chief of Psychiatry of the General Hospital in Tláhuac. The floor is yours. Thank you for your presentation, and I would like to thank the invitation for moderating this panel. It's a privilege to share efforts with everyone who's making these changes possible regarding mental health. As they were mentioning before, throughout the interinstitutional efforts is how we reach the best results. So without further ado, I'm going to present our panelists. We're going to start with Dr. Altalef. I'm just going to mention the title of the panel, Mental Health and Addictions in Vulnerable Groups. Just give me 1 second. Sorry, I saw Professor Sheinbaum and I thought it was her turn, but I'm going to introduce Dr. Estela Altalef. She sent us her general CV. She's a specialist in geriatrics in Argentina, president of the American Commission of Elderly in Assis. He is a teacher in odontology and teacher of human resources. It's a great work she does in these one of the most vulnerable groups, which are elders. So without further ado, the floor is yours. Thank you very much. From Argentina, with a lot of presence in Mexico, in the American Commission for Assis. We've moved on a lot, considering the well-being of elders. Can you hear me well? Yes. Perfect. So I don't take long. I'm gonna ask you to share my presentation. That in my case is about mental health and elders. Presentation is there. Okay. This first presentation, this first slide shows subject about diversity and complexity, about the required approaches by elders, since there are many cultural frameworks and many different life trajectories. I think that we have the advantage of reaching this period of life.
La siguiente pantalla.
Next slide.
Sí, me escucha. Bien. Queremos dejar sentado desde dónde.
We want to set the basis, and this is one of the rules. And the premises we have in CADAM, which is a paradigm of active aging, but from the point of view of wishes and values of each person. As we are all here because we act, we make decisions, we manage, or we even have some knowledge regarding our own life, but the ones who are here is because we do something and we work for elders, so we need to see from a perspective. And the one we propose is active aging according to the wishes and values of each person. And it involves the biological, the cognitive, and the functional, obviously.
La siguiente diapositiva.
Está un poco retrasada las diapositivas, doctora, pero nosotros
The slides are a little behind, but we already changed it. Okay, yeah, I can see it. Thank you. The transition we're going through implies, I don't know if we've talked about elders in other presentations, but we are in a demographic transition, and the pandemic made it evidence in an epidemiological transition where chronic diseases, which are mental health of elders, has been also in this list. And this has a great potential to invalidate, and there's the risk. It's all included in a social transition where it's obvious that their psychic resilience and wishes are starting and including elders, but in a negative context with changes of family compositions, long-term needs of caring, and require change in the social dynamic that alter mental health of all, even complete families. There's also a political transition because there's an obvious recognition in the Convention of Rights for Elders that some countries by law, so it makes them comply with it. And elders start appearing in public policies, requiring resources, and as the WHO says, adequation of the health systems. When the WHO defines mental health, talks about a well-being state where each individual can develop its potential, can confront tensions of life, can work productive and fructiferous, and it can give something to its community. And that's what we expect for elders too, for a good aging. So from the geriatrics perspective, we define it that a healthy aging is doing it with self-autonomy, with the capability to perceive conditions, to have liberties in their decision-making and in their actions, and to have an efficient exchange with their environment, the context, without taking any risk. And with the pandemic was very clear. In some places, they wanted to stay in, they wanted to keep us inside because we were older than 70s, but we proved that we could do it without taking any risks. And those who need help will get it. This is the need of partial or total help for making decision and daily life. Within the indicators of the different ways of measuring the conditions of life and the effects, the most important ones for geriatrics are the years lived in this capability. And here, mental health has a lot to do. So they have few years living with this capability and many with autonomy. There are concepts that are very important for each approach for well-being for elders, physically or psychic, and is the fragile concept. For us, is very useful to know that we need to think something for everyone beyond the context. But we all go through a process as we get older, and we lose our reserves and a difficulty to keep being balanced through different events and adapt. However, this matter seems to be less strong. These difficulties, because the psyche of the elder has developed a series of mechanisms that allow them to show a resilience that we've also seen during the pandemic. When we talk about fragilization, following the literature, we talk about 5 fundamental aspects: sensorial, vision, hearing, touch, self-perception, the movements, cognitive aspects like memory, the metabolic aspect, and diseases in general. One of the aspects of this process, if we understand aging as a process, we're going to see how there are different presentations. Here I want to show all of them are elders, but obviously each one of them proves that there are different stages, different processes, and that is not necessary to go to the last stage. But we are all going to get there, and what we need to avoid is dependency. And clearly mental health plays a fundamental role. When we talk about the geriatric patients, there are some components or many components that have to do with mental health: lack of motivation, cognitive determinant, confusion, depression. It is all linked, one matter to another, affecting each other. This process of fragilization is also in a context that determines the mental health of elders. Personal problems, less participation, non-healthy environments, the possibility of loss of their own place of living, insecurity, violence, abuse, and the effect on elders about mental health, their difficulty of accessing services. These are all contexts that condition their process. When we cross these variables of fragility with dependency variabilities, which is the greatest risk, which is a pathologic aging, and the social vulnerability, we see a situation of very high risk, extreme risk, which is the social sanitary vulnerability of elders that doesn't involve only the elders, but their children, their relatives, their communities. That's why we have to intervene integrally. So we need to understand how to understand such complexity, so many histories, so many cultures, so many habits. How do we understand all of this? Where the famous, approach focused in the person. So in elders, it's really necessary to not separate them out of the context. It doesn't matter the care or the policy that needs to be written. We cannot separate that person from their context. And us in geriatrics, we have integral assessment, which is the star to get close to this complexity and diversity and understand it. This integral assessment has 4 components: a medical component, a biological component, not without limits. Everything is mixed, but we recognize the biomedical component, the social component, the psychic component, and the cognitive component, and the result, which is the functional component, where we see the well-being or not, or lack of the elder in its functional capability, on how they can go throughout their daily life and being satisfied about it. When we talk about the profile of this sociosanitary problem with elders,
Por favor, la otra diapo. Exacto. Bien, entonces cuando hablamos del perfil de la
when we
problemas,
talk about the profile about these problems and their mental health, we see that elders present polymedication, polypathologies, and this is in red because in mental health we have a great problem, which is the limit of the benefits when we work with drugs in elders. Some of the stars of the issues of the problems with elders, these are not specific. Depression may be disguised. There may be a development,
la otra diapositiva, la anterior, por favor.
sorry, previous slide.
No sé si ustedes ya la están viendo, la que estoy hablando acerca
I don't know
de...
if you're seeing the slide about the profile. The great problem of the naturalization of medical problems as a normal aging, the high repetency of the psychic causes and social causes. And as we see all mental health problems of elders, we have great similarities between these normal problems in aging. Taking into account these great matters as the giants, what we call the giants of geriatrics, within them the instability and falls, etc. But the acute confusion with these great ones is one of the great link to mental health of elders. That's why when we do the assessment in the psychic component and cognitive component, we take into account the affective aspects, the life history, the emotional aspects, and we need to take this into account. All of us who work with elders to take care of them. The affective aspects, negative stressful situations, cognitive aspects, and both stars, the cognitive deterioration and depression. We also have the percentages, and I'm going to name that in the abuse of psychotropic substances, WHO says that we recognize 1% of abuse of this type of substances, but we need to take into account the addiction of elders to common medicines, like, for example, painkillers, gastric protectors, and anxiolytics, sleeping pills, and a great addiction, and people cannot function in the morning without taking a painkiller. That's how they develop a cascade of issues that make it worse and result very expensive in well-being and in money, family, community, and the health system. It's something we need to take into account. And another important thing, the percentage that 1 in 10 elders suffers some kind of abuse.
Doctor Altalev, disculpe la interrupción. Le quedan 3
Next,
minutos.
please. Sorry for interrupting you, doctor. You have 3 more minutes. Okay, so we are going to have to go a little bit faster. Next, please. Also, I'm going to skip some slides. So the aspects of depression, we already know what we are working with, we already know them. And WHO tells us that 7% of all population represents some sort of depression, especially bipolar 1, and it represents a high percentage of years lived with disability that are not recognized by primary care. Something interesting is that the ICD-5, the last version of mental diseases classification, has detected a minimum cognitive impairment, which is quite important in order to be able to have an early diagnosis in cognitive impairment. Next, please. We have to acknowledge and follow the activities of older adults, both the advanced, where I think that we could have the most manifestation of the minimum cognitive impairment, which is reporting, visiting, and of course, instrumental activities, which is where we define the stages of cognitive impairment, where we have to be very careful in people that stop doing the activities in their advanced stages of life. Among the social aspects, next please, I only want to stress that the educational aspect has been proven to be highly protective in terms of mental health, and I want to talk particularly on the identification that main carers or main care providers offer. The main care provider appears here with a serious mental health problem for the community in general. It is important to provide a follow-up to this main care provider to see what is their condition and to know if they are in the possibility to keep providing proper care. Next, I find the utmost important to undertake the problem of dependency and long-term care as a public health problem, and to understand that it is a relational phenomenon where the two parties intervene, the one that has to care and the one that has to be cared for. And there is a new field created that intersects, where people feel different in their identity. And it is very interesting to see how they say the same things. For example, a person that should be cared for say, I am not Maria anymore. I am a person that has to be helped for everything. And Rosa, her daughter, is, I am not Rosa anymore. I am just a caregiver. I had to stop everything else. So all of this in a political decision setting, beliefs, rights, laws, legislation, funding, who does the funding, the private or the public sector, and the social imaginarium that always puts the burden of care at home and in that home on women. Could you please give us a global comment to start concluding your presentation, please, doctor? Yes, of course. So ageism is one of the main topics on mental health problems in old adults because of the context in which it is developed. Next, please. Myths, prejudice, and mental health that put us in a situation that we cannot move away from. Next, please. And this is a series of phrases that are demolishing for old adults, and we'll hear them everywhere. So what do you want to do at your age? You won't understand this, you are old. Well, so these are the other challenges. And in Argentina, there was a survey, a poll by Dr. Yahoo et al. He is the head of old age subject in Buenos Aires University. And his work is on 757 old adults during the pandemic. And, well, seniors in general have complications in their regulation, and some groups had less resources, such as women, younger seniors, and those living with family groups. So it is interesting to analyze and to do something about it. Next, please. And this is the one that describes this trial and the action of seniors in this survey. This survey shows what we have to think of and what we have to further develop post-pandemic times. And the last one is the conclusion. So we would like for what we want is for a senior not to have their reality being their main pain and suffering. And we want for the life control to be seized by the senior themselves. Thank you so much for your attention. This is a very interesting topic, and as you very well say, we every day see that population gets older and older, and with this we have the appearance of chronic and degenerative diseases, as well as cognitive impairment that brings us to the loss of independency. And most of the family members are the ones that end up being the informal caregivers. There are a couple of questions in the chat, Doctor, that I would like to go over with you. Sure. Some of them I'm going to read. And the first one is, how do you provide training in aspects related to populational aging and mental health problems such as dementia and related mental disorders? Sorry, could you read that question again? How is education provided? How training is provided? Yes, how you train people in populational aging and its relationship to mental disorders and diseases that are related to it. Well, we would love for it to be more frequent and thorough in every field, not only in medical fields, because there is no healthcare professional that won't offer their services to a senior, and this senior may have some of these problems. It is being done generally in most of the countries, I believe, at least in America, in a way that is not enough in terms of its scope. That's what I think. Great, Doctor. Thank you so much for your answer. So we are going to modify this dynamic because of the time we have left. We are going to go for the next speaker, but the questions that are for you, Doctor, I will send them to you, Doctor. Perfect. Thank you. So now I would like to introduce Diana Sheinbaum. She also sent her resume. She's a partner and founder and coordinator of the program Discapacidad y Justicia Documenta. It's a civil society organization founded in 2010, and its goal is to work in favor of human rights respect on people with disability. She brought this legal request at the UN on behalf of Arturo Medina Vela. It's the first case solved surrounding Mexico, where it determined the international responsibility of the state. Diana is a co-author of a study, Violation of Human Rights in Mental Health Centers, and she's part of Collective Mental Health and Human Rights that work to promote an amendment to the regulatory framework in terms of mental health and addictions. Without any further ado, Doctor, thank you so much for being with us today. The floor is all yours. Thank you so much for the kind invitation. I wanted to ask you if you can see my screen and if you hear me well.
Ya vemos su pantalla.
We can hear you and we see your screen. Perfect. Thank you so much. Thank you so much for the invitation. As you can tell through my presentation, in Mexico, as we say in Mexico, I am really standing out here because I am a civil organization that is in charge of defending human rights of the most affected populations, which in this case, by injustice, which in this case is persons with disability. And I want to refer to this because this is the starting point of my presentation. Documenta is an organization of Mexican civil society founded more than 10 years ago. And as I told you, we accompany in different ways subjects, victims of victims that have been subject to human rights violations that have been trans-institutionalized. And by this we mean persons that spend most of their lives in different types of institutions, jail, psychiatric hospitals, clinics for addiction treatment. So it ends up being a never-ending circle. So this is the result of the accompaniment and support that we have provided for more than 10 years to these victims of human rights violations. As I said before, during the introduction, Documenta is the organization that brought Molina Vela's case before the UN. I don't know if you are aware that Mexico is the country that promoted the creation of an international treaty in the UN, an international treaty on the rights of persons with disability. And in this collective, we have psychosocial and intellectual disabled persons. So Documenta brought this first case of a person with disability, a Mexican person with disability with psychosocial and intellectual disability. And the sentence of the committee,
Se ha estado trabando un poco.
sorry for interrupting you, your connection is intermittent. So maybe you could turn off your video, please. Great, thank you. Okay, hopefully you were able to hear what I was telling you before. But Documenta brought this first case before the Committee of Persons with Disabilities, a UN body that found that the Mexican state was responsible since they violated their responsibilities within this international treaty. So in 10 years, we have shown the approach that we've had with different authorities. And at the end, there is a report that has been published that's called Because It Was Necessary, and it collects not only the testimonies of users of the services, but also the multiple recommendations that have been issued by human rights commissions when related to mental health. Today, the panel is related to mental health and addictions in vulnerable groups. And I would like in some way share with you a broader vision of vulnerability that's not necessarily associated to what are called priority groups or very specific collectives here in Mexico. I'm talking about vulnerability related to mental health and addressing it in a different way. And to this, we relate specifically understanding and providing the right weight to social determinants related to mental health. I'm talking about violence in the country, corruption, inequality, puts all of us in a vulnerable position. And these violence contexts in unequal position are the ones that could bring us to look for mental health support and services. So we are all in this vulnerable situation in one way or another, and hence we are potential users of mental health services as such. We believe that it is necessary for this amendment, the one that happened in the general law of health, to understand that there is a different way to understand mental health. Something that that health rapporteur mentioned is understanding mental health not as the chemical imbalances, but to address it from a power imbalance point of view. So mental health brings us to vulnerability and once again to the most important aspect, which is the social determinants and the way they have on mental health. Also thinking about vulnerability from the point of view of violence, corruption, inequality, discrimination, and how it affects us. So mental health is not only a field of action of the health system, but we also need the deep co-responsibility of other sectors. For example, the housing sector, educational sectors. Another focus that I find to be very important when talking about vulnerable groups is stigma, and here specifically related to people with psychosocial disability, persons that use the services that have been sharing from decades, exclusion and marginalization stories. I think that stigmas is one of the reasons explaining the huge gap that we have in mental health attention. And this is very interesting to address. In the amendment to the general health law, there is a need to fight stigmas and prejudices associated to mental health disorders. And it is addressed, and that is great. And this stigma and these prejudices move around in a sort of pendulum that interrelates psychosocial disability with being dangerous on one hand, and on the other hand, with assistentialism and with the idea that people with psychosocial disability cannot generate a project of life and make their own decisions. So the fight against these stigmas and prejudices is of utmost importance when talking about vulnerability. On the other hand, we see that at Documenta, one of the factors that increase vulnerability in the context of mental health has to do with the access to mental health services and how centered is today. The fact that the mental health care access is still in psychiatric hospital makes makes services to be inaccessible, unequal, and affecting hence vulnerable groups the furthest out. So today, someone living in an indigenous community, isolated from the most populated states where mental health services are focused, for that person will be very hard to have access to these services. So we are talking about the lack of access, which puts people in a vulnerable situation in terms of care and attention. Besides the access to service and the need to expand this service, I think it is fundamental to talk about service quality. So once we reach them, what are service users facing? And during this support that we have provided to users and former users, we've realized that in institutions, there's still the idea to perceive them as just main beneficiaries, which demands a reproposition in the relationship between mental health professionals and mental health services users so that they consider them as full recipients of human rights. In the research that has been done throughout the years, some of them in charge, for example, by Dr. Shoshana Berenson, it's clear that there is a huge discrepancy in the population's needs in terms of mental health and what services do to meet them. So mental health services should, as Dr. Shoshana was saying, should put people at the center. And this means understanding what their specific needs are, and not only starting from controlling the symptoms and diagnosing, but also how they live and where mental health problems are placed. So I think that a pending job would be reducing the distance between this discrepancy lying in the population and improving services based on the user's opinions. And this reproposition of the relationship between professionals and users also has a lot to do with the possibility of establishing support alternatives and services that are based on giving back the users their control and decision-making on their lives, because control and the capability to make decisions constitutes a requirement for well-being. Another aspect related to service quality, and this especially focused on addiction, refers to the lack of supervision existing on the services provided in treatment clinics. As you know, the percentage of treatment clinics that are supervised and regulated, formally regulated, is minimum. And in some way, this places users in a vulnerable situation once again, because the lack of surveillance and oversight makes it possible for these unsupervised, non-monitorized, non-oversight places see human rights violations, mistreatment, and violence. There are multiple reports and recommendations by human rights organizations where they have monitored clinics, treatment clinics, and psychiatric hospitals, and we see how lack of surveillance and monitoring many times leaves users defenseless. I believe that this Congress comes in a very relevant time, specifically because of the reform to the general health law in its chapter of mental health and addictions. It is a reform and amendment that was published in May this year, and I find it critical that everyone related to mental health services and addictions to be able to read the amendment and understand its scope. The amendment echoes and it's based on addressing these two main pillars that I discussed. We have accessibility on one hand, and the need to, at some point, materialize this promise unmet by Caracas Treaty in 1990 that showed the need to repropose the policies of mental health and mental health care model to leave aside this monovalent and psychiatric care and to move forward community-based approaches. So the amendment published in May 2022 proposes the necessary integration of mental health communities to primary care, as well as this is going to be a huge challenge because the law is always one step further. But now there's a need to understand how this law will be implemented, especially taking into account that, for example, 80% of mental health public spending in this country is dedicated to psychiatric hospitals, and that we live in a Republican austerity stage. So we have to understand how in this context we will implement an amendment that will help the population. So this is the first pillar, the mental health amendments. The second pillar of this amendment has to do with quality and quantity associated to respecting human rights and to place at the core the will and preferences of the person. This proposes the prohibition of practices violating human rights, such as isolation, involuntary committing, and institutionalizing, and it places at its core the idea that recovery and services in mental health have to be always based in informed consent of people that accept them. So these are the two pillars of the amendment, and there is still a long road to walk. There is still a lot to do, and it has to do with our day-to-day and our practice with mental health professionals to be able to change the way we understand mental health and not only understand the psychopathy, but also addressing it. And this is the takeaway message. The right to health is not the right to be healthy, but the conditions and services that lead to a dignified, equal life without discrimination in terms of health. Hopefully that in the time we have left, we can have a dialogue conversation and go over the questions that the audience may have. Thank you very much for your attention.
Muchísimas gracias también por su presentación.
Thank you very much for your presentation, Dr. Sheinbaum. It is a very interesting topic, and it is not really frequently addressed as it should be. It is also important considering that people and populations could be in vulnerable situations, but not in a fixed condition of vulnerability. So when people are truly in a permanent vulnerable situation, facing adverse situations without the right resources to address it or for remediation, they are not considered vulnerable anymore, but people that have already been vulnerated in their rights. So we need to address this topic that happens every day in our patients with some mental health problems. ISSSTA is sharing resources to address this. People have talked about Code Purple that sensitizes medical professionals in the care of patients with some sort of mental health issue or disorder, and to sensitize them in these topics. The ISSSTE also has a specialized clinic of attention for people living with HIV, the San Fernando Clinic, that's formed by a multidisciplinary team that's also focused on the person, that has a person-based approach. So these efforts are aimed to improve the situation of vulnerability. Once again, thank you so much for your participation. We are going to leave the Q&A session for the end. And now we are going to go to our third presenter, Dr. Olivia Lindau Chilean Herrera. She has a master's and doctorate in science by the Public School of Mexico of the National Institute of Public Center, and she designs and monitors the projects in social health. She has developed as epidemiologist on environmental approach and in the scientific approach on the National Service on Nutrition. She has also worked with PAHO in the development of documents for decision-making, as well as in the coordination and development of massive training courses in environment, virology, and in climate change and health.
Como coordinador en investigación y planeación estratégica, y coordinó el diseño de los estudios nacionales de calidad de la atención y los servicios de salud y guarderías en CAL. Actualmente, la doctora Chilean...
Currently, she's in the general direction of IMSS as coordinator of priority projects, like strategies for mental health during the pandemic, in group, also for groups in vulnerability situation with a gender perspective. Welcome, doctor. Hi, good morning to everyone. Dr. Jose Alberto, it's a pleasure to greet you and a great pleasure to be again in this great event. Thank you, Dr. Eunice Valle, someone I had the pleasure to meet in the actions regarding these mental health actions. A big hug, because working with you gave us tools to develop the work that I'm really thankful of, to share with you what we're doing in IMSS regarding addressing mental health in these groups of vulnerability and how this works in this complexity as an essential component from a systemic perspective, from a human rights perspective and gender perspective. Before I start my presentation that hopefully you see,
Claro que sí, doctora, se escucha y se ve perfectamente.
yes, we can. I want to talk about this today because besides being a great day for us in IMSS, because we present the work we've done collectively throughout months to improve the attentions we have for these groups. It's also a day where we can talk about this mental health issue from a motion from our general director, who instructed us throughout the experience about the pandemic and analyzing which are the impacts of the actions we're having as institutions. And it made us to create this institutional policy to help these vulnerable groups with this principle of the fourth transformation without leaving no one behind or outside. And we did it in collaboration, an extraordinary work where we had participants from different areas. A very complex exercise because first we had to attend to see which are the groups, the vulnerable groups, and how can we prioritize. And we chose these 5 groups: elders, pregnant, children and teens with cancer, HIV patients, and persons with disability, because we see in these groups a series of variables that gives them also a lot of inequality, so that the actions we have don't have the expected effects. These populations represent 10 millions of persons, so that we get an idea of how big this policy would have. This work has been a work in cooperation, very complex, where we include many tools. We have strategic teams with experts in matters of health, human rights, social security, all of these priority groups. And we sit down to do the systemic analysis that these groups have to protect their own health rights, and being able to develop strategies with better scope and more accurate. It is a working collaboration that it's a huge effort that it has taken a lot of work, and today is going to be presented in the social network of IMSS. So we invite you all to know what this institution is about. Beyond the ad, I want to focus in these systemic analysis and their causes. What we find is a crossroad where mental health was transversal to all groups of vulnerability, but as a risk factor. Loss of quality life, loss of a healthy life, adding years of unhealthy life, and it has been unvalued socially, medically. When training professionals, we even exercise psychological violence. So we identify that we need to do something else if we want to see the results in this population to be more feasible. We also see that there's a series of mental health issues that are not recognized as such. It's not about being crazy or not. There's a whole spectrum with variables, risk factors that can be preventable, multi-cautional, and this way of seeing mental health hasn't been understood by those who are in this health system, and we are still in the medical focus to all of these spectrum of mental health. So imagine if this is the general view with these groups, how big is the problem? It's way bigger, because as such, these groups are already a vulnerable group. And if we analyze deeper, all of us are recognized as persons that have been through a mental health issue, and the clearest example is from the pandemic. We cannot deny that mental health was at the focus of the attention, not only in health sector, but also within our families. And this view in this institution that addresses more than 8 million people, it's one of the biggest in Latin America, which implies to make priorities. That's why we make these policies, this analysis, where we had this dilemma of finding the causes of the problems we wanted to solve, to have the actions that we want to achieve. Literature and scientific research has given us a lot of evidence that tells us where do we need to walk from, and to transform these in operational plans with different complexities of a system as ours is very difficult. If we also add the addictions matters, we may think that mental health is before the addictions, is a risk factor to develop addiction. So a vulnerability situation can be seen from many perspectives, from many variables that interact within each other in a very complex way, which makes us more in risk to develop a mental condition and as a consequence addictions. But mental health as such puts us in a vulnerable situation that makes us more to take action. So it's a root variable that we need to take care of. How do we think that the best strategy, thinking about the priorities and challenges, is to think about the preventable issues? Nothing we haven't seen before in other presentations. And what they mentioned about the different sessions of the International Congress, in our analysis of causes, when building our groups, we identify some axes that we need to identify: stigma, discrimination, ageism, these prejudgment, abandonment, inactivity, loss of functionality. In the groups of children and teens with cancer, everything that comes with confronting the uncertainty of a sickness that has such delicate predictions, but not only the patients, but also in their support networks, parents, caregivers, people with this capability. As Dr. Dana commented, stigma discrimination in these groups, the discapabilities, acquired psychosocial discapability, and how we perceive it, exclusion, prejudice. HIV patients, they also suffer through stigma. And in our 5th groups, pregnant women, we believe that mental health doesn't reach this group, where we impose a series of gender stereotypes that don't allow us to see that mental health during pregnancy is very important. We need to fight the trauma of giving birth, of obstetric violence, mental health in puerpery, also the postpartum depression, or when pregnancy occurs in teens. All of these variables have to do with mental health. And if we think about how all of these interact between each other with these gender perspectives, we see that the problem is very complex, but it's common within all of these groups that one of the variables or elements that increases margination of these vulnerable groups and others that are not mentioned is the stigma and discrimination. Consequences of all of these mental health issues that we are not seeing systematically are multiple, and I want to highlight it because they need to be put on the table so it's clear that we need to take action very soon. To not request support for our caring our health, which leads to late diagnosis, have a root in the stigma and discrimination. In these mental health issues, abandonment of treatment, these conditions, the discapability, increase of health costs for the sector and the families, more complications. All of these are preventable consequences if we act effectively in the mental health of the most vulnerable groups. Our exercise was concluded in this document, which is sustained in the focus of human rights. We call it the Pentalog of Human Rights, which includes all of these components to take action, to improve the care of these groups and their exercise of protecting their health. This establishes the guidelines we're going to use from the Institute transversally to materialize all of these rights, to make all the means are accessible for everyone without discrimination, adaptable, so they are flexible to adapt to the needs of different groups that are acceptable, how we need to adjust things, and the people who is directed to as subjects of right, that they are available enough for all people in any part of our country, and they have the quality and the requirements to comply with the objectives they were designed to. One of the axes of this policy has to do with mental health for everyone. This is a first time in the history of the Institute, and we're very proud that we can work in collaboration, but still we need to see how are we going to go from theory to practice. We have already action with many results, but it's not enough, and we know that we recognize that we still need to see the difference between the attention, the pathology, mental health, and see the preventive focus. That doesn't mean that we need to change all of the actions. We're working in strengthening primary care with training to first level staff, filtering the main mental health disorders, depression, anxiety, panic, with the help of first level caregivers, also to fight stigmatization and discrimination when giving attention. This is an access that we will highlight because the results here need to be reflected at a short, mid, and long term. And that's why we need to have alliances and joint efforts. Regarding prevention, which is where we need to focus on to attack these risk factors, we need to work in addressing the social determinants of the mental health together with the sector and within the institute to fight stigma and discrimination. And attention also so that people can reach it or request it, or even we can avoid the development of these issues or the complexity of them. Active aging as a preventive measure. This is a tool or an element that we will focus on to decrease the problems such as Alzheimer's, dementia, that now affect the elders, which is our biggest population. Attention of risk factors that can be modified, where we need to work in collaboration with other areas of the institute, and it's very clear. Taking care of attending the situation as a complex matter that it is. We also have working with agreements with Bajo and ASIS to establish these tools for these prevention strategies regarding creating awareness in many aspects. So actions are not only for our subjects, but also the general population. And also to understand that all of us are potentially in living a problem of mental health. Design of specific strategies, because we need to recognize that the IMSS population has particularities regarding the general population. They work that have social security and burnout and problems related to work health, and their relationship with mental health are more frequent. And lastly, our participation as an axis is to care about the mental health, not only of our workers, but also the support circle that take care in many points of their lives to other groups. This is what we're doing, and we would like to hear more and better strategies to make reality these ideas, these rights, because even if we are talking about it and we are working in favor of the groups, of these vulnerable groups, we are also capable to strengthen the health of everyone, because we are all different and we need the same rights. So thank you very much. We are here for any questions or comments. Thank you, excellent presentation. Thank you for sharing something what you do in IMSS. And now we're going to go to Q&A. Thank you to everyone who has sent their questions, very valuable. And we need to take advantage of that. Do you consider a minute for answering, please? One of the initial questions is taking into account that it's multifactorial so that the elder lives with mental health. How has the government addressed this problem with these assistance, resources, hospital, etc., to attend more efficiently this matter?
¿Alguna de ustedes quisiera contestarnos esta pregunta?
Anyone would like to answer?
Sí, por supuesto, no tengo el video habilitado.
I don't have my video on.
Me parece interpretar que la pregunta viene desde
I think that the question is from Mexico to Mexico, but we have common things.
Tenemos cosas en común. En Argentina.
In Argentina, we are carrying out some efforts, and I believe that these efforts are still not enough. There's a lot of dispersion of intentions, efforts, resources, but I think that still the central view is not focused and the comprehensive listening to elders. Pandemic in that sense had an important role to put them on top of the scene, and it has allowed them to hear and elaborate some of the answers that may be adequate on how to continue. But I still believe that this matter, even if it's still an institution as PAMI that has the medical and social resources for elders, is still not installed generally. This integral view, which is extraordinary. I heard the different presentations, and there are so many things in common in everything we've seen regarding mental health. And in the elderly, it happens because this mental health is installed in the body. So that's why we have all the difficulty. Thank you, doctor. Thank you very much. I'm going to repeat the question to see if other panelists want to apport something else. Taking into account that for an elder to live in mental health has multifactorial aspects, how does the government address this problem? How do they address efficiently this matter? I'm going to talk from our own perspective. The fact that a reform was open is a great step to take into account, to approach this problem systemically has no recipe. The social determinants that we have and that come or are cause of these mental health issues, and also these vulnerable groups, it's very complex matter. We as professionals need to design the mechanisms to make it real. The support is there. We are here all collaborating to support each other and see how we're going to make all of this reality. But it's obvious that it's not just for the health sector.
Un gran número de nuestros
And also a big number of our audience has been talking about being afraid of getting old. They've expressed it in many different ways, and I think it's something that we all have, a vulnerability inherent to human beings, and it's something that we need to work on. So in this sense, they ask, what do you consider from your experience that needs to be done to avoid this being scared of growing old, still being functional, and if it's going to be backed up by the government? Personally, I believe that first to consider that the best vital experience is to grow old. This fear actually is very linked to abuse. If elders were feeling better treated, we wouldn't be so scared of aging. And also we have the internal scared of what happens with my senses, with my relationships, with my losses. And all of these requires intervention and company throughout their lives. And regarding being to this stage in a satisfactory way, there are two main components, the individual component and the opportunities that the context and the economy are showing us, but we are part of that. We build all of that, and we need to defend our rights. And I believe one of the main things that elders can do is to recognize their rights, realize that there are laws and conventions that talk about their rights. And as it was mentioned, there's still a depth there, and to be there and be the stars while defending their rights. This will make it more satisfactory, this stage. Thank you, Doctor. Dr. Chillén. Yes, thank you. I believe complementing what Doctor said is related to the scare or the loss of functionality. These prejudgment of aging that we've seeded throughout decades and that we cannot lose sight. It has seeded the same system where they sell a series of products. It's useful for this system for us to be scared of aging because we buy creams, anti-aging creams, and things to not look, to not fall in this box of useless.
En esas publicidades en nuestras decisiones personales,
and
en
we
el
have
prejuicio
to
que
think
adoptamos
how
para
this
nosotros mismos,
advertising
también
plays a role in our personal decisions, how we address ourselves, the people surrounding us. We are all carried that same way. And in other cultures that are not so exposed to this type of advertising, this deceitful advertising, because that's what it is, because with aging, we do not become useless, we just change. We start a new stage in our life. So we see aging as the enriching of experiences, the possibility to improve the quality of life of everyone with what we have experienced throughout our life. So a community view is more collaborative. That is what we can, as population, aim to adopt, to move towards a collective dynamic, a support collective dynamic, where jointly we can make our own aging environments in a healthy way, healthy aging environments. That's what I would like to say.
Excelente, muchas gracias. La maestra Shane.
Great, thank you, Dr. Shane. Dr. Sheinbaum, are you there?
Aquí estoy, apagué mi cámara porque no tengo muy buena señal, pero aquí ando.
Yes, I'm here. I turned off my camera because I don't have very good internet connectivity. Doctor, would you like to add something? Yes, I think that I cannot add anything to this particular topic, but I just want to readdress what Dr. Estela said. How to re-signify care and dependency relationships, you know, aging and fear to aging is quite related to the reality with a lack or loss of independence. You end up losing control of your life project, or that's what you believe at least. So I think there's a way to create care relationships or support relationships where this person is centered. And also there's a text by Mexico to create services for seniors so that they offer the greatest degree of autonomy possible. So there is a pending debt on that, but I think that this has already been addressed before. Thank you so much. And at times, you as a family member can anticipate this loss of autonomy a little bit. Many times it happens that family members start undertaking some functionalities that the senior adult would do, but cannot do anymore. So what they cannot do anymore, they stop being permissive because they are afraid they will get hurt, or they may be in a situation that places them at risk. So this is how this loss of autonomy starts playing an important role. So being more inclusive with seniors, of course, can keep them functional for longer. And on the other hand, it is indistinctive, you know, the possibility to go to schools, for example, for seniors. Here in Mexico, there are colleges for seniors that are not really aiming for them to have a formal education in a certain career. Well, yes, they do for trades or for things that will keep them busy. And of course, always preserving this idea of feeling useful in a society and also in such a way being autonomous. If possible, I'd like to add something. I think that seniors do not have to allow people to do things for us. We have to strongly work so that we can keep on doing things ourselves without risks, you know, without any risks. Yes, we've been bringing questions together, and something that we're doing and seeing now is that people are eager to know what are the programs that the different institutions have. Even at the IMSS, we have our patients, our users, but some of the services that they could enjoy by being account holders, well, they do not know all of them. Their family members, for example, are also receiving psychoeducation. They invite them so we can all learn together and we can all walk this road together. So taking advantage of the minutes we still have left, doctors, there's a question. Do you have any programs that develops people's skills? People with vulnerabilities, please share two programs that you are particularly proud of or that you think that could have an influence in people that are listening to us. Please, doctors.
Bueno, ya me adelanté a abrir el micrófono, pero doctora.
Well, Dr. Estela?
Mi experiencia,
Well, I will talk about my experience. There's a word that really touched me, pride. Until 4 years ago that I retired, I was chief of socio-community department prevention for social welfare work for retirees with a coverage of 5.5 million seniors. And I am proud enough and very eagerly share with you I have proudly defined the social community prevention and social program that was based in stimulating capacities and the inclusion of seniors in their social community environment as a fulfilled member with specific goals targeting movement stimulation, cognitive stimulation, productivity, interrelationships, reflection, but concretely, this is interrelated to budget and resources of all types. Human resources, community resources provided by public institutions in agreement with public and private institutions where people, the PAMIS account holders, were invited to participate in any resource that would allow them to keep their activity to the fullest. This resulted into a great satisfaction and pride, and that's what I feel proud. Especially because it's a social work by the comprehensive health of seniors, and these resources were health strategy at the end of the day, and we were able to prove it by means of medical trials, laboratories. So we were able to keep and to prove that it was worthwhile. So I know that there are many countries that are organizing this. However, they need to be accessible. How can people have access to these programs? For example, if I have high blood pressure, I go to the pharmacy, and in any country, I will buy enalapril. But if I have any other condition, it may be related to a metabolic syndrome, so I need to have access to a physical activity as a right. That will be one of the things. And I am also training and educating caregivers for seniors, which I find fundamental, and that provides a great level of satisfaction. Thank you very much, Doctor. Wholeheartedly. Thank you very much. We continue with Dr. Olivia. Thank you. Well, at the Mexican Institute of Social Security, there are multiple strategies. The reactive and preventive focuses. And many of them are directly related to mental health, and they influence mental health. We all know that some of the risk factors due to which we can develop mental health issues is economic instability, lack of social security. This vulnerability puts us at higher risk in life. So in this sense, the Institute has worked favoring the incorporation to Social Security from groups that have been historically vulnerable. For example, domestic workers. And as I said, it may appear not to be directly linked to mental health, but it is, because we are trying to pay one of the largest historical debt with vulnerable groups. And also, well, I'm trying to select the strategies. I'm talking about the telephone mental health support group. I worked with Dr. Eunice Vale, and she, as a health professional, is one of the great stars that the Institute has had, because a paradigm was broken in mental health care. During the pandemic, we faced a complex overview because we realized of these gaps in order to address health. Since we had a population with multiple mental health issues as a result of the pandemic, and they needed attention, they needed services. So with the institutional efforts and the collaboration of everyone, this telephone hotline was open so that all account holders and non-account holders could ask for care via telephone. You didn't have to leave home. This service is still available for account holders and their family members, where health staff, psychological health staff, provides support and containment in cases of crisis. This was a great effort that will be relaunched because the most complex part of the pandemic may be over, but problems are still there. So it is open for everyone. Also, the senior clubs for older adults, this is one of the great strategies that will be scaled because it has given amazing results in older adults that have been prescribed participating in these clubs and that recognize what are their rights. So they participate with other seniors from their experiences so they can improve their qualities of life. And there is trained staff that offers psychoeducational activities, physical activities, as well as others. The gap is still there. We recognize that in an institution, and the one that provides social security and protection in Latin America, was just saying that being able to have a stable and standardized coverage without discrimination is highly difficult and complicated, but we are insisting because the commitment is clear to us. This is for everyone and it has to be for everyone.
Doctora Olivia, muchísimas gracias. Y pues bueno, yo quisiera complementar un poco.
Great, Dr. Olivia, thank you so much. And I would like to add something about what's done at the ISSSTE. We have gerontological modules distributed throughout the country in first-level countries where we have integrated mental health professionals so that we can also address the situation that we see more frequently in our old adult populations. We see neurocognitive impairment and deterioration, and we see anxiety, depression. And at the Tláhuac unit, which is where I work at, there are 16 Code Purple beds where we can admit patients since they are teenagers until when they are in their teenagers years, or if they are older adults. And it aims to address another program, Ecos para el Bienestar, that tries to raise awareness on mental well-being and not only leaving it in the hands of the health staff, but also taking control of it, of your own mental health. And due to the time we have left, we cannot elaborate on the different programs that we have in our different institutions. I think that we all together at the end of the day are focused on improving a situation that requires a greater approach and firm results. So in this sense, I don't know if any of you would like to share any general conclusions. All of the presentations have been master presentations. They have complemented each other. So we would like to thank the participation of all of you and everything that's done in these institutions, which is of utmost value. Yes, I would like to address a common issue. It is necessary to put people at the center of actions and reflections. I also found another thing in common, the being unaware, not knowing the existence of resources and answers to at different levels. So this is common in my country. The same thing happens to us. If you come closer, if you approach people, they mention not knowing what their rights are. So a challenge would be how to address the territories and where the problem is, and doing it interdisciplinarily and intersectorially. And I also believe that it is at least for older adults or seniors, but let's not wait for demand to happen. Let's just go out there. Before.
Muchas gracias. Sí,
the rest of the members, you have 1 more minute each. Yes, I think that the 3 presentations go back to putting people at the center and respecting the rights of mental health services users. There are different tools that have been shared, conceptual, technical, that have been shared to ensure a dignified attention. So what's relevant is that this focus has to be fundamental part of all professionals' training, not only on mental health, but also on health in general. Thank you very much. To conclude, I would like to confirm that the comments of my fellow panelist members are shared by me. And I am very glad to see that at the Mexican Institute of Social Security, we are on a good way. We are on a good path to reinforce gender perspective in human rights. These are the right way to materialize a person-based approach. And I just want to add that we are aware at the Institute of all of the challenges that we are facing, but also the commitments that we are working to consolidate so that account holders can feel it every time they go and ask for care and contribute closing the inequality gaps that have been historically imposed.
Pues, doctor Altalev, muchísimas gracias.
Perfect. Dr. Altalev, thank you so much for your passion.
Doctor Olivia, gracias por la
Dr. Sheinbaum, Dr.
Gracias.
Olivia, thank you so much for your visions. Dr. Telles, for your company. We will continue with the next presentation, and congratulations, everyone. There's no health without mental health. Thank you, everyone.
La lucha contra las adicciones requiere de un esfuerzo conjunto.
Fighting addiction requires a joint effort, education, and strict measures and actions, and it requires all generals to join the fight. And for this, work team is of utmost importance. For our next topic, integrated networks in services, integrated networks throughout the states. What have we done in mental health and addictions in Mexico? We have Mr. Francisco Javier Fernandez Clamon that will give us a great presentation about it. We will welcome Francisco Javier Fernandez. Currently, he's the Secretary of Health and General Director of the Institute of Health in the State of Mexico. He has a master's in health institution management by Anáhuac University. He has a master's in psychoanalytical psychotherapy for children and teenagers. Achievements: he has strengthened mental health services as well as addiction treatment and prevention in the state of Mexico. He has a great professional career. I will try to sum it up. He has been director of the Mexican Institute Against Addictions in the state of Mexico. He has been also a representative, municipal president in Cotitlán Ixcali. In the Honorable Town Hall of Cotitlán, he was director of social development, government director, and municipal director of human rights. And he has been a joint postgraduate studies professor in the Faculty of Medicine at UNAM, as well as joint professor of pregraduate studies in the Faculty of Medicine at the Pan American University. This is a brief summary of Dr. Fernandez's professional career. Dr. Fernandez, the floor is all yours. Thank you so much for your participation. Thank you so much. You are so kind. I would like to salute Dr. Juan Manuel Quijada Gaitán, Director of Psychiatric Care, Dr. Celida Duque Molina, the Director of IMSS Medical Services, and the topic that I will address today are comprehensive networks of health services. Life has brought me to the municipal, state, and federal levels. And this has allowed us to see in operations, as well as in planning, the great decision that has started with this administration in terms of health, and being able to bring together mental health and systems against addiction has been a very timely decision. That's why there was an amendment in health. One of the aspects that is discussed amongst the different subjects covered by the amendment, the main one is bringing together mental health and fighting addiction. And one of the fundamental aspects was on May 16, 2022, where we see that comprehensive care networks have to be managed and open, and especially the implementation of these networks has to be very well synchronized from the community all the way to a specialty hospital or a psychiatric hospital. So the article was amended Sorry, I lost audio.
¿Me podían pasar la siguiente diapositiva?
Next, please.
En esta diapositiva lo que estamos observando es que está
Here we can see that the National Mental Health Plan 2019-2024 covers different aspects, and one of them is integrating mental health in the first level of care, of attention, a primary mental health care. But there are also fundamental aspects that are being carried out: suicide prevention and child and adolescent mental health. These are seen from prevention and treatment of addictions as well. Something that we've also neglected is mental health, birth, death, and mother and child mental health, as well as older adult mental health. And I want to tell all of you that promoting, preventing, care, recovery, as well as training of our health staff is principal, is our main focus. This slide very well exemplifies the new mental health and addiction model that the federal government has developed and that has been implemented as we see it in this model. First, we have health determinants. Health determinants includes biological, social, economical, cultural, environmental, and health services elements. It is targeting the individual, the family, and the community. And it also reaches community care, self-care, and creating a network from the first level. People throughout the states with psychiatric hospitals
O ellos mismos habían pedido.
when diagnosed with a mental illness, would go to those psychiatric hospitals. We have 3 of them. However, there are states that do not have any psychiatric hospitals, so they will have to go to the country's capital, to the psychiatric hospital Fray Bernardino in Mexico City. So there was saturation as a result. So the first contact of people is their health center or their health home. And in the state of Mexico, throughout the territory, throughout the state territory, we have 1,221 first level of care units, out of which we have health centers. There is another model between the first and second care level, which is one that has already pediatrics and gynecologists for labor support. And people, staff received training according to the MHCAP guidelines, so that our colleagues, not only medicals and paramedics or physicians, but also administrative, so they have a knowledge on the 7 most frequent mental disorders so that they can diagnose and refer them to our primary care center for addictions, our mental health integrated centers that have 34 layers. In Mexico City, we are the city that has more facilities to this end. And the conversion is being done towards mental health and addiction community centers. What for? So that diagnostic is done from the first level of care. We at the State of Mexico have done some amendments. For example, going through the Ministry of Health in the State of Mexico, and this is, and when visiting these centers, there is an exhaustive, a comprehensive examination. But today, it includes gynecological services, so a mother can go to their child to undergo a psychological evaluation to know how the first years of life of the minor are developing. Another amendment that was done was in pregnant women. Every pregnant woman, especially if they're teenagers, they need to go to psychological care services to receive assessment. Let's remember that most of pregnant women, teenagers or also adults, could have a pregnancy that's a product of abuse or rape or violent action of different types. So we need to work on developing the psycho-emotional aspect from its beginning.
So these community health centers will have this functionality, and also hospitals. We have 71 hospitals, 35 are community hospitals or municipal hospitals or integral. It's depending the needs. Also the general direction for health planning, and also from those 71, we have some medical staff in more than 50 hospitals, where they have a very important network for care, psychological care, psychiatric care, and the thing is that we need to start having beds for psychiatric emergencies. And also we have our psychiatric hospitals, 3 in Acolman and Iztapaluca, and the most specialized of the psychiatric hospitals or the National Health Institutes. Next slide, please. So the first level, we're working with brigades, health centers with this new model, our specialized centers, the CISAMES, the integral mental health centers, and we have normative responsibles in our jurisdictions, because before mental health was just a second term issue, and nowadays it has as much priority as other programs. Also the specialty programs, and then the specialized hospitals. Next slide, please. So the Secretary of Health, these are divided into Secretary of Health and the Institute. In the Secretary of Health has 34 centers. ISEM has the Subdirection of Prevention and the Subdirection for Medical Care, with all the mental health programs of the all levels care hospitals. Subdirection of Epidemiology, with all the sexual transmitted disease. We are present in 97 municipalities from all the psychology personnel, into municipalities with psychiatric hospitals, and 18 municipalities with UNEME CAPAS, and 3 municipalities with CISAMES. We also have the National Council for Well-Being, the homologization of mental health and addictions, and from September this year, we also have a integration of the mental health services and addictions. In this process, we are going through phases. We are the institution with more trainings in MHCAP of all entities about this network that we've created. More than 13,000 trainees. We have tables where we have public policies from the municipalities, and in the state, we have 55 community brigades where we do filterings to the population, and we start also with medical students, and also regarding preventing suicide. Here we have more than 283 brigadists with more than 55 brigades. We have detected in topics violence against women, criminal activities, and the high risks of suicide in the region. Also, we are working with the psychiatric hospitals in 5 hospitals. Also, 3rd-level hospitals with beds. We are doing visits in all hospitals for the new model, trainings for MDHCAP. And for the first time, we're working organizedly and together with this new model against addictions and in favor of mental health in all entities. I finished with this, and this new model, I believe it's really assertive by the federal government and all the psychiatric care services that also has a national service and the state service. We've been working with different institutions of the state, like DIF, INSEMIR, ISSSTE here in the state of Mexico, IMSS, and regional hospitals like from the federal level and the state of Mexico. We are a team and we need to have these integrated networks to service people. Thank you very much. I guess this is an intervention we can learn a lot from. We have a couple of questions. We want to share them. The first one is about the brigades. The question is, where can we identify these brigades? And if they go to the communities, or if there's some calendarization for these brigades to visit some municipalities. And the second one, they ask if in the experience of the state of Mexico regarding the implementation of this new model, if you have searched for the opportunity to include the telemedicine in this great model. Both questions are very interesting. Yes, we have a channeling based on indicators, epidemiological indicators regarding mental health, because one of the indicators is a matter of the research files regarding suicide, also the use of psychoactive substances, also regarding gender violence in 11 municipalities. We also help where there's a community matter of disaster of social disorder. For example, these brigades were used for the first time when the Chiquihuite mountain vanished, and we had many losses, material and human losses, and different factors like PTSD, depression. And from there, we have the filtering with the use of substances and other matters of violence. On the second question, yes, we've implemented these because of the scarcity of psychiatrists in the whole state of Mexico. We are also present in some general hospitals and psychiatric hospitals, obviously, but coming from these telementoring, we developed it with other psychiatric hospitals. And we were linked with our specialists of internal medicine or emergencies, or even psychologists. And we've had a lot of success with this new model with these specialists from psychiatric hospital and our units. Thank you very much, Professor Javier Fernandez. We thank you for your participation, and we would like to close this great conference that you just shared with us. I love this type of speeches because we see that we are more general than we imagine, that all our work is really giving results. I would love to think that these efforts to know all of these data, to know this approach, and to identify how we are working more closely and in harmony, it would have an effect in all professionals, like in me, because I'm feeling willingness to do more in favor of mental health. Thank you for your invitation, and it's very gratifying to work in the state of Mexico. And I saw this project growing, and now being the head of the Secretary of Health, I'm glad to know that I can do more. Thank you, and greetings from the Governor Del Mazo. Thank you, Professor.
Sigamos. Este próximo panel
Let's
realmente
continue. This next panel is really exciting because the basic part to make alliances is to learn from the experience of the allies we find. The guideline for intervention, MHCAP, it could be essential to determining the well-being, and it's going to show in the benefit of our population. Now, Dr. Daisy Corrales Diaz will go through the experience of our panelists. Well, I'm very glad to greet Dr. Daisy Corrales from here, from the International Congress on Mental Health. I'm going to be very brief with her resume. She is licensed in medicine and surgery in Costa Rica. She has a master's in health service management. In her trajectory, she was our director of the Inter-American Center of Security Services. She was executive director of the project of modernization of the Global Bank regarding health ministry in Costa Rica, national director of the Costa Rican box, and she has a lot of experience teaching, managing public health services in a private and public sector. Of her achievements, we have a lot of she has a lot of experience in health services, working in many scenarios nationally, locally, and regionally. And she managed cooperation projects and the same national policy about mental health in San Jose. Welcome, doctor, and I'm very glad to greet you. Thank you. I'm very thankful for your invitation. And I know that these interdisciplinary groups and interinstitutional group, I feel at home. I'm very glad to see all the advancements presented and the efforts in many aspects. Being a leader and also to focus different actors to talk in these roundtables. So thank you very much. The panel I indicated, and I thank you, Dr. Palacios, for inviting me to this activity. It's about caring mental health by implementing the intervention guide, MHGAP, the national and international experiences. This topic is one of the most complex, especially if we consider that this intervention guide is directed to people who's not specialists in these areas, and it's created for mental disorders and by substance abuse applied in the first level of care, since it's one of the sources of the systems where we can see to achieve the implementation of these guidelines requires a multifactorial action. Here, as we heard with Javier Fernandez, we have to add, besides all of these actors, besides the local governments and institutions, we also, the user, because the services are focused on them. So we need to consider this to determine of these social determinants, and that makes us understand that the union of different institutions, educational, security, ministries of different disciplines or secretaries, they also need to intervene to determine the health where we have a lot of variability. So today we have the pleasure of having in this panel 3 speakers, Dr. Laura Elizabeth Cavazos Cárdenas, Dr. Luz Alejandra Cano Callado, and Dr. Alina del Canto. These persons are directly related to this complex implementation process that we're going to talk about. Also, here in Costa Rica, we have had the experience that it started many years ago, but in 2012, made us create a national policy for mental health that it turned 10 years actually this year in 2022. And it has a lapsus to restructure this policy according to the events that we've gone through its implementation. We also have the first of all, we're going to have Dr. Laura Elizabeth Cavazos Cárdenas, Chief of Mental Health Department and State Link MHGAP from the Mental Health and Addictions Direction from the Health Services of Nuevo León, Mexico. She's a surgeon by the Autonomous University of Nuevo León with the specialty of psychotherapy, for couples therapy and family therapy by the School of Medicine of the University Hospital of the Autonomous University of Nuevo León. She has been a psychiatry and clinical psychiatry in external consults in the state of Nuevo León. She has coordinated congresses and training in mental health and addiction, and she has been a speaker about mental health matters. So welcome. You have the floor. Thank you very much. Good afternoon. It's a pleasure. I'm very grateful with the organizers, and I send my greetings from the Directive of Health Services in Nuevo León, and I particularly would like to thank Dr. Jose Javier and Professor Blanca Leal and the rest of the national authorities that are taking care of this work with this guide. Thank you for considering Nuevo León a state considered by many privileged, including mental health matters. And I'm going to give you an overview that is a little bit more realistic about why it is so important to have this intervention guide of MHGAP in our state. Can you help me move forward with the slides? We know that this guide created by WHO at the beginning of 2008 was to train ourselves about mental disorders as epilepsy, dementia, and the disorders caused by the use of substances in the non-specialized level. However, to quote Dr. Cugues, where MHGAP is a tool to promote the inversion and access to mental health, because it also impacts the fact that many people who are trained as psychiatrists are not trained to work with addictions or these disorders as epilepsy and dementia, which are very specific. And we also don't have the training to care completely this complex phenomenon as suicide. So imagine the impact for these specialized physicians, and why do we have the need for all the staff from first level when Nuevo León is a state that has training in psychiatry from many institutions, as the University Hospital of the Autonomous University, IMSS, and Tech Salud. Also, the Psychology School of the Autonomous University, UT, the UT of the Regiomontana University. It's a lot of information, so it seems that we are very privileged. So we need to find this reality. This program comes as a response to the lack of staff of mental health in medium income countries and the big load of human mental health conditions.
Psiquiatra infantil y de la adolescencia en el 2004.
I was a child psychiatrist and teen psychiatrist, and we had a program called Specialist in Your Community. And I was in different health centers of first level, and the demand was huge, and the need for care of children was really necessary, as determined by the WHO, where we start with the 50% and with our child population, we see the diagnosis of these mental disorders. The experience with MHCAP in Nuevo León started in April 2012, where we started doing courses of 120 hours. And we wanted to do of that staff more psychiatrists, when actually it was necessary to point out what was it that they needed, so that in these 2 years that we've been helped from the federal part, we've been closer to the protocol of MHGAP, PAD, and humanitarian MHGAP, so that the staff can really get the knowledge, and therefore they can solve that first level problems, and when is the reference going to be done. So we need to have good leadership. We have it from the federal, and I consider to be a good representative here in the state, also together with Dr. Alma Estrada, who is my state coordinator, and she has become in the second year in my right hand to continue with this commitment. So we need to have a continuous surveillance for that trained staff. It is important to have enough medicine and continue with this vision, this teamwork that also Nuevo León has 8 jurisdictions, and 4 urban and 4 rural, with great leaders and mental health coordinators. And there we have the list. And I would like to thank all of these work they have helped me do in these last years with these great colleagues. So we have 85% of our goal covered, with 93 facilitators who have reproduced this course to more than 400 suppliers in the state. In this meeting, I'm going to show some pictures, and here they have been able to tell us their experiences, their success experiences as MHCAP has changed their lives, how they are now allowed to see the importance of mental health, and that it wasn't possible to have health without it. So with this new knowledge, to be able to look for the symptoms, find it, and do the diagnosis to establish treatments according to this organized guide with many support of PAHO to feel that their practice changed, that their life changed, that their view changed, and how easy to listen to them when they are repeating this guide with the state colleagues, and realize that it seems I'm listening to a colleague who is an expert in psychiatry. It's wonderful to see how these abilities to explain the topics with that level of security. One of them even changed from their health center to an area that could get her closer to work with this type of patients in Cadereyta. So the objective of our guideline is to improve the capabilities of general physicians and all professionals as psychologists, social workers, nurses, many residents, to modify this primary care regarding identifying the diagnosis and treating of people with mental disorders, neurological disorders, and the use of substances, strengthening the system of the health network, including reference and counter-reference with specialists when it's needed.
Entonces, vemos cómo la aplicación.
So we see how applying this guideline requires the interrelationship and the creation of networks where we have to work together, the different stakeholders, so that educational activities, sports, cultural, social activities are brought together. And you can see how they are enjoying the reception of their manuals, as well as version 2 of the MHCAP, the Humanitarian Guide, and the PAP, as well as a recent picture of our state committee, which is a mirror of the National Strategy of Addiction Prevention and Mental Health and Suicide Prevention in Nuevo León. So here we see how through this merge at a federal level, Nuevo León already was fortunate enough to have a directorate on mental health and addictions, a joint one. So we already worked in an interrelated fashion. And to be honest, the support of mental health services is provided in the 28 CAPAs. So CONADIC also works on addiction prevention, and as well, they always worked on mental health. And now with this conversion, it is clearer for us. However, even with all of the privilege, the few psychiatrists that we had abandoned us. And we still need physicians at this UNEMESCAPA in order to increase the reconversion models so that they can turn into the next SECOSAMAS. So most of them do not have a complete staff roster, so we are needing human resources. But we can also see how through this mirror national strategy on addiction prevention, we have technical secretaries, such as myself, and we have my Yolanda Ramos Luna as the coordinator of UNEMESCAPA at the state, this 28 UNEMESCAPA. And How's the rest of institutions doing? Sepúlveda, Cultura, Safety, Security, Citizen Wellbeing, Labor, CONADE, CONAP, all of the other institutions in Mexico. They are working jointly with us, and the goals that I just shared with you are trained staff by the Ministry of Health. However, this training has been open to the rest of institutions that have health staff and that need to know of these mental health problems, neurological and substance abuse. Next. Also, we've worked with physicians in second-level care hospitals emergency departments, providing psychiatric emergency postgraduate studies and certification so that they understand the need of these 2 beds in the general hospitals, so they can also know that these are medical emergencies and that they shouldn't immediately consider that this patient has to be referred to a psychiatric hospital. But nonetheless, we have one in the state. And we are about to open 2 spaces
en el municipio de Sabinas.
in Sabinas,
Obviamente,
Morelos.
pues hablando de este éxito y porvenir sobre nuestra guía de
success
intervención MHGAP, pues la
on our
importancia de
MHCAP intervention training course, we have manuals, which is of utmost importance, and we apply these guidelines, and we can all actually now have it in our mobile homes. So it's hard, I know, in rural areas to have internet connection, but the challenge is mainly having Sentinel pharmacies with health departments and available drugs, so our trained physicians, our MHCAP trained physicians, can prescribe them. We need further human resources, as I said before. And we also need follow-up and supervision of trained colleagues so that through telemedicine or telehealth efforts, they feel supported by the specialists in the area so that the population in its community can be addressed, not only diagnosed, but also 100% cared for in any stage of their lives, facing the impact of a mental health disorder. When someone experiences a mental health disorder, not having economic resources is quite painful, not only for the patient, but also for the entire family. So I believe that this is where our quality as health providers forces us to be available so that this impact is reduced as much as possible. And hopefully that from the federal level, INSABI can take control in the need to cover human resources and drugs, so it can send it to each state. Thank you very much for your attention. Thank you so much, Dr. Cavazos, for this amazing presentation. And I would like to congratulate you and Nuevo Leon's team for this amazing job that you've done with the MHCAP guidelines. As you can very well see, when we discuss this further, besides having training in clinical guidelines, this also forces us to plan when we start in mental health care in the first level. We are talking about very important strategic coordination so we can increase coverage of care, so we can use a comprehensive model to promote health, prevent, and heal. This, of course, requires all the organization that we have just been told. It also needs screening to know reality And we also need to create all of these networks that have been discussed throughout the entire Congress. We need initiatives that will allow to have an organizational behavior organized in levels where the patient can take control of their own mental health problem. There is also an important aspect that was mentioned, which is resource distribution. We cannot just come and train, but that there has to be an entire resources with pharmacological departments. We need to approve physicians that do not have any specialty to use drugs that specialists use. This also from institutional point of view. There is a huge amount of drugs required, and we need to make distribution networks more agile, and we need to make them available to the first level of care. Also, the information systems were mentioned. Here it talks about communication and digital technologies that come hand in hand with primary care, and they should be strengthened. And there is also an important aspect here. Mental health, when we talk about general medicine specialists or interdisciplinary care, there was a variation in attention and care times. Sometimes you need to have 5 appointments to be receiving mental health care. So this has to be done faster. And now we're going to continue with our second presentation, Dr. Luz Alejandra Cano Callado. She is the Deputy Director of Continuous Education. She trains and educates members of the INSABI. She has a master's in public health by the University of Tabasco and also surgeon. The Institute of Health for Wellbeing in INSABI. In there, she has been Chief of Continuous Education Support Department, as well as Educational Content Support, and a permanent resident of mental health. She has been a collaborator in the implementation of health training, and she has provided MHCAP training in mental health, and she teaches development in the Autonomous University of Tabasco. She's author of scientific articles and papers on the academic performance 2019 of the Public Health Masters in Tabasco. Dr. Cano, welcome. The floor is all yours. You have 18 minutes, please. The floor is all yours. We are quite expectant and excited to hear your presentation. Thank you. Thank you, everyone. Could you please allow me to share my screen?
A ver, listo, ya tengo los permisos. Okay. Bueno, nada más me confirman si ya pueden ver mi pantalla.
So, could you please confirm that you can see my screen? Yes, we can. It just needs to be in full mode. It is.
¿Sí se ve pantalla completa?
Doctor, I think there's a problem with the broadcasting. We cannot hear you. Okay, I'm gonna stop. I'm gonna turn off my video to see if it works. We can hear you now. First of all, thank you so much for inviting me to the Second International Congress on Mental Health. I am going to talk about mental health care by means of the implementation of the MHCAP guideline. I am so glad to participate in this panel with experts in the matter. I am going to focus on talking about the actions that we have implemented at the INSABI here in Mexico. And I'm also going to talk about some other actions that we have applied for the health department and health staff. Well, as Dr. Laura already mentioned, mental, neurological, and substance abuse disorders cause a great burden of disease and disability worldwide. So there's a need to provide services to the affected persons and their caregivers, reducing the gap between the available resources and the huge need for these services. And to this end, the Department of Mental Health and Substance Abuse of the WHO started in 2008 the program of world action to overcome mental health gaps. It's called MHGAP. This is the English abbreviation. And the goal of this program is to strengthen governments' commitments and other stakeholders in increasing human resources as well as financial resources to address mental health disorders. Here, I would like to talk about the INSABI. It is a decentralized body of the federal branch that has legal personality and their own resources. It is integrated by 4 coordination units. I work at the training and education coordination for staff. This is the chart flow of the health staff training coordination. This is Dr. Toledo. And below, we have our unit, which is formed by 3 directorates. Also, Dr. Yesenia and Dr. Cesar. In this chart flow, we work to implement the continuous training and education We also have the picture of Jose Carlos Mendoza. He has been a fundamental foundation to carry out mental health trainings at our institute. In the specific case of MHCAP guideline training, we have also worked with Dr. Blanca Real. I would also like to add that in the Organic Institute of INSABI, Article 41st talks about planning, coordinating, and assessing training courses. These training courses are normally targeting the health staff, providing services to those that do not have social security. We have to enable the attention model that's promoted in Mexico. And actually on October 25th, the official Gazette issued the model. It's known as Más Bienestar program. And we have carried out different input provision as established by the general law on health. This new model is based in principles and the practices of the primary care services. It will also allow to improve the performance of the Mexican public health system. Sorry, her internet is cutting a lot, but I'm doing my best. This model talks about health staff training. Health staff needs to be trained with a primary health care approach. Here we have the different priority strategies per health impact. We have the strategic topics for the model implementation and cross-sectional competencies for the staff. As I showed here, the national strategy to address mental health includes the MHCAP guidelines training. The model also mentions that the basis for staff training will be determined by the Ministry of Health, but we are going to work together jointly at INSABI and other sector institutions to regulate staff training. Last year, in October 2021, we created the educational system on health for well-being. This is an educational platform. It is based on MOS, which is a learning system. This has the educational offer by the institution that I work at. And we have more than 122,000 persons registered. The attention and care model will be a school control system, preferably associated to the control systems for institutional staff. And the platform already offers the training course on MHCAP guidelines. I'm going to show you the progress that we've had in this training course implementation. The training course is done along with CONADIC, CONASAME, Psychiatric Care Services, and we did new recordings, and we added a new module to the training course, and it was launched on April 21st. Since that day until November 30th, 36,401 health professionals have registered, and 77% of them, represented in green, already passed the training course, and it's already trained in MHCAP guidelines. 21% is still on attending the training course, and only 2% has failed. When this happens, we at the platform, we try to have a customized staff approach. So if the staff has any problems passing the training course, because the MHCAP has to be concluded in 12 weeks. But we always try to provide customized attention to health professionals and solve their needs as soon as possible. This is something that we have established in our coordination. So if anyone has any difficulties, we will enroll them again in the training course so that they can pass it. This graph shows the different states and the staff that's enrolled. Most of them are in the state of Mexico, Mexico City, Chiapas, Yucatan, and Hidalgo. These are the same states for the staff trained per state. We have Mexico State, Mexico City, Yucatan, Chiapas, and Hidalgo. In the case of the staff that's been trained according to work category, most of the ones receiving training are nursing medicine, and another one includes auxiliary health services, chemists, or odontology. And here you can see the percentage of approval per work category. This is from April to November 30th. This is also the enrolled staff according to their hiring institution and the trained staff. Most of them have been treated by the health department, followed by the Homeland Security and then INSABI. In this slide, you can see how it looks like when the staff enrolls in the training course. This has 13 modules, as I told you before. We have a violence module. Among others, we have a pre-assessment and a post-assessment. I'm going to take a time to mention what other actions we've done in terms of mental health. And on July 21st, we launched the training course on hate speech and women in diversity. 858 people have already passed this training course, and 571 are still attending to it. Dr. Mendoza helped us in cooperation with Dr. Lu Quintero, and this was a result of the need for people in the community facing obstacles when trying to exercise their rights, and due to their gender expression, identity, etc. So these are part of a person's individualities, and under no circumstance should this be a discrimination condition. So I'm going to tell you what else we've been doing. Yesterday, Dr. Roosevelt was telling you that the first action in terms of training at INSABI were a program called COVID Duty. This is a program of an open mic session that was created in December 2020, as a result of training needs in COVID issues. In 2020, mental health sessions were discussed and the need to hold them. That year, 38 sessions were held. These mental health sessions were coordinated in cooperation with Dr. Mendoza, and as I mentioned, the program was created in April, but in October 2020, we had 15,051 attendees. Then in 2021, we had 50 sessions on mental health at COVID Duty with 6,182 attendees. And these health sessions were afterwards referred to at COVID Duty's platform. This is the link in case you want to go over it. And by the end of 2022, the program underwent a change. There was a COVID-19 seminar, however, new of them were added to the portfolio of the INSABI's staff training. And on January 6th, we opened the permanent seminar on mental health. We have 8,191 attendees, and we can also register training events now. There are INSABI assessments also carried out to this end. I'm sorry, I lost sound. We have also included MHCAP guideline trainings, as well as other seminars. We've also been doing this work along with the National Commission for the Prevention of Addictions. As you can see here, this is the overview on how to depathologize mental health issues. There has been some progress in mental health approach, and we are still working so that we can work jointly with other health services and institutes. We've already talked to IMSS Bienestar in order to train their staff as well. And actually, IMSS Bienestar has also adopted the training course in our platform. However, today we are creating strategies to send this updated training course to communities that have limited access to internet. So that's what we are doing today. And next year, we will be working on support sessions on the training course. And to conclude my presentation, we would like to invite you to register in CIESABI in the Educational Center on Health for Well-being. This is for health professionals and health staff. And it goes all the way from administrative, cleaning staff, lab staff, everyone can register. And in the case of the citizens, all of our conferences and all of our educational content is in repositories. So you can have access to it if you need so. MHCAP sessions can be found also on Facebook. Our social media are called INSABI Educación. So you can go over all of our information and all of the actions that we do in terms of continuous and permanent education at the coordination.
Y dejar de compartir pantalla. Aquí espero que sí se haya escuchado bien.
Sí, doctora Luz Alejandro Cano, muchas gracias.
Thank you, doctor. Thank you very much for your presentation of all of the efforts from INSABI, training staff from different institutions, which is very important. And also what you just mentioned, so that community in general can access to these different types of training. Maybe not from the clinical part, but there's a very important part that you mentioned about the medical staff, the different profiles we have, where throughout the process, there should be a company of a sensitization process. So in that sense, I think that the community people, the institutions and different profiles should participate. Thank you very much and congratulations. We will continue now to Argentina, to the Ministry of Health of Argentina. We're going to talk with Dr. Alina Alcanto, Coordinator of Prevention Area of the Mental Health Direction. She's a psychiatrist with a master in addiction. She has a postdoctorate in systemic therapy in Palo Alto University. She has been teacher of psychiatry and mental health in Lisboa, Portugal, coordinator of the program Mental Health in Pajo, and director of health services. She had a great participation in different conferences, trainings, and different regional encounters to prevent, assist, and prevent of suicide. She's coordinated the telephone line for support and organizer of in the province of Mendoza. Welcome, doctor. Thank you very much for the invitation. It's a pleasure to be part of this Congress. Argentina is playing in the World Cup, and I'm very happy to be able to participate, so I'm very grateful. Can you share the screen? Or should I share it? I'll try to share it myself. I cannot share. I have no permission. You can share it yourself, or we can do it. You have to give me permission. Luz has to remove her material, and then I can share. Okay, there you go. Can you see my screen? Can we share it, doctor? Yes, it's okay. I would be grateful. Okay, there you go. Well, just to tell you that I coordinate the training and prevention area of the mental health direction of Mendoza, Argentina. Mendoza is a province with 2 million inhabitants. I depend from the provincial direction for mental health, where we have been working since 2016 in different strategies. We have different action lines. One of those is the assistance in emergency and disasters, the telephone line of 148, which is a care line for everyone who needs it, professional health attention. Since 2016, we've been working a lot in prevention, assistance, and a recovery after a suicide in the community, with the problems of the suicide. And another strategy that we're working on since 2018 is the application of MHGAP guidelines.
Bien.
This is a brief tour. I'm going to tell you where are we today and how has this strategy worked for us. My colleagues already mentioned the objective of the training of this guide, which is to diminish the gap in mental health attention, to improve accessibility, and always understanding the difficulty in the resources to have psychiatrists in the first level of education in health centers. Argentina is no exception to this. Mendoza is distributed in different departments and in different regions, where in the first level care, we have 1 or 2 psychiatrists in health centers by region. and some other regions are completely far away, and the resource, especially psychiatry, is distributed in specialized hospitals, which are we call monovalent. We have a law in Argentina, the National Law for Mental Health, since 2010, and the objective is to facilitate the access to health in the health center. So in the first level of attention, with the redistribution of human resources of specialized hospitals or monovalent hospitals to the community. It's a path we've been following with the difficulties that we obviously had, but we want to widen beds in general hospitals. In 2018, the General Direction of Mental Health, together with PAHO, lowered this strategy, MHCAP, and invites all provinces to have a referent of this MHCAP for training. So in 2018, the PAHO started training in the province. We chose 20 educators to train them on how to apply the guide, how to repeat it, and how to use the dynamic tools, the videos, role play, witness cases, and different actions, how to start replying and train on this guide. We started in 2018. In 2019, we kept following the departmental experiences with the first level of attention, family physicians, nurses, sanitary agents, non-specialized staff in mental health to be trained in this guide. And the difficulty was that the reference that we chose, mental health professionals, they could continue and they were available for these trainings. In the area that I coordinate, we have 4 colleagues. We chose more people. And unfortunately, the persistence continued, not only for training, but the big challenge for me and with the people I work with, it was to continue with the monitoring and a follow-up of all of those people who were trained. In 2021, because of the pandemic, since the increase of mental health issues and suicide attempts, we started working strongly. We continued virtually, but the Ministry of Health started to take more relevance regarding mental health, and is not only to create awareness, but also in other sectors. So, and they started requested contention spaces, and they started to assimilate the importance of having the first tools while listening, accompanying anyone who may have a mental health problem, and have the first tools to help them. So in 2020 and 21, we continued virtually, but what make it easier is that the province and the different sectors started to listen and ask for mental health tools. In 2022, in this year, the Argentinian direction download with the PAHO the strategy, and Mendoza has been one of the provinces with the most continuity and developments in this strategy. As I was saying, in 2018, we chose psychiatrists, psychologists, and social workers to be trained with the PAHO. First of all, what we did in the province was sensibilization, especially in a ministry level, at the level of the highest managers so they could understand the need based on the fact that we can have these trainings, but if we didn't have an alignment from the top, it was very unstable. So we made this awareness, and then we continued with the training in person by department. Mendoza has 18 departments. Each encounter, there was this in 3 to 4 hours of training, where 2 hours are theory and 2 hours role playing and distribution and see complex cases. We do 3 to 4 hours with a monthly encounter. We have a period of 7 months. We go each time to a department to take this strategy. This sensitivity, awareness that I was talking about, held that since 2016 as axis of first level care. We've been working with the departments to have intersectoral networks. So not only MHCAP training, but also once a month we work together with health, sport, education, youth, social development and work to think about preventive strategies regarding each department and the needs. Especially this was very relevant since 2021 with the increasing of mental health problems, especially suicide. In the guide in 2019 was to take pre-test and post-test offered by the guide to know the contents. In 2020-21, regarding the increase of suicide, we've been working hard when there are suicide about children and teens. Forensics tell us, and we work that day and the next day at his or her school to work with the other children, the community, to avoid connected suicides and preventive strategies. So in the increase of suicides in 2020 and 2021, everything related to health and interinstitutional became more relevant. Another thing that we played in our favor is that we started working in hospital and health centers to accompany the staff that were in overload or stress for self-care and mental health accompany, since they were more of the most exposed groups. So our presence in the pandemic and the suicide situation in universities, because there were 3 suicides of students in 2021 in the universities, our presence created more impact that it was to be applied in this resolution, the strategy to strengthen the first level and MHCAP. Still in 2020, we have the modules. Also, the phone line was activated, 148, with psychologists to take care of any problem of mental health. And what we started is to adequate this guideline of 2018 and prepare it for 2022, where we could include a module about the care, self-care, and exercises, breathing exercises, stress management, and healthy lifestyles for staff, medical staff, which has been very well accepted, and also the PAD, which is fair psychological care to all medical staff. During this year and last year in November, we made the first campaigns in inter-ministries from sports, education, health, development. We made these campaigns to make a diagnosis of the impact of the pandemic. We work with teens and children, and the commitment of all the ministries for 2022-2023 to work on prevention of mental health interinstitutionally. These campaigns were fundamental for the image gap strategy, and the Ministry of Health sends to every ministry the guidelines of first level care, primary care, and the resolution, the image gap is included in this. So today, health centers knows that once a month, I have the capacitation and we have protection from the ministry. So this year, we repeated in 2018 with another impact, including self-care module and stress management in medical staff. And we have a bigger commitment of the coordination of areas that can be added. During this year, in the trainings, the best challenge is that after this, how we can bring a company so that the trainers can really feel trained to do the first intervention, and it doesn't stay in training. So that's why when we finish modules, we do a monthly encounter with all the departments to think about complex cases and take care about some complex cases and what else do they need so they feel trained for that first encounter. These brought different discussions. The Psychiatry Association first was very against it because they thought that this guide was to train psychiatrists and get their jobs, or I don't know. But they could understand also based on the need that the people with mental health problems, as the physicians trained in RSP, and they have to be trained in the first contention with communication tools regarding mental health. This is a picture of some of the encounters this year, since they are in person by department, and we go once a year. This year, we've been around 400 professionals trained who still work with their patients, mental health patients, and in 2018 and 2019, we trained around 700 professionals. This is what I was mentioning that we included in the module, taking care of personal staff. And what we started to include is how we can think on assessing the impact of this strategy to know if really after the training, professionals do feel capable of taking care of these problems, like a pharmaceutical treatment. And above all, we wanted to assess how many psycho drugs would they prescribe before and after training. And what got our attention is that they prescribe less. So thinking positively in responsible medication and the rational use of this type of drugs, when giving a company and training, they start to listen a little bit more of what the problem is about, implement the psychosocial strategies from the guideline, and to be able to think that this prescription of drugs is the last strategy, and very responsibly and carefully. Here, one of the challenges for next year is the monthly encounter and supervision who are part of the network. After training, we give them a survey and we ask them if they want to be part of a network of mental health care. Those who want to are included to a WhatsApp group, where through that network, they organize complex cases or urgency cases that may find in their daily lives. We're creating this network to improve accessibility and also to have cores of mental health professionals, so they have telehealth when it's needed from the first level to a second level. Of the 400 trainees in this year, these are some of the questions, if they have a periodical space for these encounters. For them, it was very enriching. This is very important. It's a question if they did this training cycle, if they has allowed them that before a mental health problem, 47% says that they feel in conditions to take care of it until a specialist may be available, but they can be the first contact. So if we go out of the training and we continue the follow-up, monitoring, and surveillance, then professionals will feel even more trained and more capable of doing that first encounter. 23% felt to have more knowledge, but not still in conditions to take care of it. 11% could do it as long as they have a specialist to consult. And purple is to take care of it, knowing the knowledge and a company of specialists. Can we go to the next one? The strategy was useful, practical for them to take care of these mental health issues. Next one. And that's it. Thank you very much.
Doctora Daisy, tiene el micrófono apagado.
Thank you, doctor, for your presentation. I think that with these three presentations of experts, Dr. Caro, Dr. Cavazos, and Dr. Del Canto gave us a clear view of this process of implementation of MHCAPS, where we see which is a planification strategy, and it's clear that it is stage of creating the technical team with its strengths and weaknesses, but the availability of specialists, training of a certain level for a group as PAHO and WHO, so that specialists are capable of doing training for the first level of attention, and very interesting things regarding things about the different groups that have different risk and we need to take care of, so that this dynamic regarding mental health is going to evolve depending on the conditions around it. Very important things about being aware with the monitoring and consult causes to create more specialized fields, like addressing suicide from the prevention approach. Because if we talk about treatments, there are requirements, for example, beds in the second level of attention to strengthen the interdisciplinary teams. For example, in Costa Rica, only CISAM, who are these interdisciplinary groups, and strengthening the complex areas because we're going to have critical patients that need to go to a third level of attention in this type of problems regarding guidelines. We have some questions, but also comments. We have one for Dr. Cavazos. They ask about what would be the main motive for psychiatrists and why is this a key point to implement a high quality service? Well, definitely to psychiatrists, we are hired as general physicians, not as specialists or subspecialists. So this is one of the motives why this virtual world has a lot of advantages, but also a bigger load. And also that they don't only attend addictions, but all users that require all of those who need mental attention, those who in the private consult, we are saturated with very severe new cases where most coming from this pandemic that we haven't finished. Many of the patients are very severe conditions because of this suicide risk, where fortunately we are trained and they are in the NMS Kappa trained in this care using camps, in this collaborative management to take care and stabilize in 8 to 12 sessions and do the follow-up in the next years that the MHCAP guideline tells.
So this is the reality that I wanted to share with you and that is experienced in the state of Nuevo León. Thank you very much. We have a comment by someone working at the ISSSTE, and they're saying that the problem is that there's not that much interest in having this training course because there's no incentive to work in mental health. So it is an important topic that we have to take into account. And we are asked to share once again the link where the presentations are going to be uploaded. And there is a congratulations to all of the presenters for their amazing presentations. And actually, you will find an invitation by the Mexican Institute of Social Security to be able to also participate in trainings via the CLIMS system. They have shared the link for anyone that wants to have access to the training program and incorporate in any of the TEMS. I would like to thank and to leave you with a reflection. TEM are complex. However, we've all evolved in time. But I think that we already have statistics and monitorings that could help us strengthen this system. In Costa Rica, we have a small population compared to Mexico and Argentina. It is 5,163,000 million inhabitants, and health system coverage is 90%. we've been able to separate governance activities directly at the Ministry of Health or in the Secretary of Health, and they do not provide services, but do all public policing and monitoring. And for the organization, we have 18,000 professionals that incorporate psychology, psychiatrics, voluntary work, nursing. But an important aspect is that there is a difference on what it used to be originally. We used to have 100,000 psychiatric medical appointments only. And now we annually have around 60,000 interdisciplinary appointments. And this shows an expansion to the concept of mental health for everyone, with a significant increase in coverage and service quality. So thank you very much for all of your participations. And we conclude this roundtable. Thank you. Thank you, everyone. See you. Thank you. It was an honor. Thank you and congratulations.
Muchísimas gracias a las panelistas por sus
Thank you very much for your presentations. Dr. Cavazos talked about my dream, being able to talk about psychiatry with other physicians in a common language. Dr. Ledesma, on how this dream is becoming a reality, and also the importance of training to look after ourselves and among each other, and an amazing conclusion by Dr. Heredia. Now we will continue with the next roundtable. Every change requires leaders, people with vision, but with a heart too, willing to break paradigms, willing to bet on innovation and to think in a different way. The world is going through a key stage for mental health. These leaders have identified the times, educating, understanding, working in teams, and providing experience. And that's how we are changing psychiatry, as well as attention and care models, giving a first round to mental health services. It is an honor to introduce the members of the next roundtable, entitled Advances in Reformulating Mental Health Care Models and Addictions. Hello, so I would like to introduce, as a moderator, Dr. Jorge Julio González Olvera. He's a doctor in sciences at UNAM, doctor in medical sciences at UNAM, surgeon with a specialty in psychiatry by UNAM and the National Institute of Psychiatry Ramón de la Fuente Muñiz. He is currently Director of Development of Mental Health Problems in the Technical Secretariat of National Mental Health Council. He has been a director of the General Commission Against Addictions, CONADIC, a deputy director at the National Institute of Psychiatry Ramón de la Fuente Muñiz, researcher in medical sciences by the coordinator of the National Institute of Health and High Specialty Hospital at the Ministry of Health. He's also a member of CNI Level 1, tutor in CONACYT educational programs, and psychiatrist. He has several scientific articles published in national and international journals. He is a pioneer in the world of psychology and psychiatry in Mexico. Hello, I would like to thank everyone for inviting me. I'm going to be very brief. In today's, in the Congress presentations, we've seen very important aspects in an effort to reformulate mental health care and addiction models. And they have happened in the different sectors and in the different institutions. They provide a lot of information on the reality that we have to consider to implement this new model. For this roundtable, we have 4 speakers. We are going to have 15 minutes each, and we're going to see some experiences, two national and two international. So I am very glad to introduce Dr. Miguel Caldas Almeida. Dr. Miguel Caldas has a PhD in psychiatry in the New Medical School. He's currently president of the Global Mental Institute in Lisbon in 2017. And his professional career. He is a professor in psychiatry and mental health since 1990 until 2017, coordinator of the mental health program in PAHO, director of mental health services in Portugal from 2006 to 2011. Dr. Caldas is a national coordinator of mental health and in charge of the implementation of the National Plan on Mental Health from 2008 to 2011. He was a coordinator of the Joint Action in Wellbeing and Mental Health in the European Community and co-chair of the European Cost Action for the Reduction of the Use of Coercion in Psychiatry. Dr. Caldas, welcome. Let me see if you have already joined. Yes, can you hear me? Perfectly well, doctor. It is so glad to see you. Oh, we have dressed with the same sweater. Good afternoon, everyone. First of all, I would like to thank this opportunity to be once again at a Mexican meeting. Mexico is a country that I visited many times when I was in PAHO, and I hold very dear memories of the participation in mental health amendment at that times. I would also like to say hello to the rest of the members of this roundtable and to everyone that's participating and listening to this roundtable. I will speak in Spanish. I didn't know that there was interpretation services, and now I already have my presentation prepared in Spanish. My Spanish is a little bit rusty. It's not great. However, I hope that it's enough to communicate with you. I am going to share my screen now, my presentation now. Can you see my presentation? Yes, doctor. Okay. So, for the last 30 years, in the time that has gone since the Caracas Declaration all the way to the World Report on Mental Health that has been published some few months ago, many things have happened. And especially about mental health models. I believe that what we have to see is that, first of all, there was a lot of progress in knowledge. If we compare with the situation and the way it was some decades ago, we need to recognize that we know way more on the determinants of disorders and the size, the load, and also what it means and what mental health represents in society, especially after COVID-19 pandemic, that has shown around the world that it is of huge importance. Also on MH, also on the treatment gap and the different service models. In the meantime, there has also been huge progress in the concept evolution that had already started. If you remember the way in which mental disorders and how they were used to be believed, as well as mental health services, here, as you can see, things go changing. They have a more biological perspective now, a psychological perspective, a social perspective one, and today it is a converging one that is way more than just bio plus psycho plus social. Also on disability, and this is important because many mental diseases and disorders are associated to disability. All of them have adhered to a strict medical model that's a comprehensive one. And today it has a whole new human rights perspective. So mental health services and mental health care has been moving conceptually, not really practically, but conceptually, from a hospital-based perspective or approach towards a more community-based perspective, and including a recovery model and a human rights recovery that are still having a very large impact in the way in which mental health services are modeled and characterized. This World Mental Health Report, for those of you that haven't had the opportunity to read it, I would strongly suggest to do so. It is a very enriched document, very well structured, very well written, and offers a great summary of one of the main topics, which is mental health. For example, talking about models, I believe that these two slides show everything we know on scientific validity. And the first thing that the report describes very well is that at the center of mental health amendment, we have an important and significant reorganization of services. And we also have two simultaneous tasks. One is how to provide a care to serious mental disorders, moving from institutions towards communities, and at the same time, improving responses for problems such as depression, anxiety, the common problems in the community. Both strategies are critical to improve both coverage and quality of mental health care, and as well to promote human rights. Today, we know that in each district or city, we need to have a service network that's based in the community that can be easily accessible for people with a huge range of mental health conditions. And this network has to also address social and economic needs that people experience, people with mental health experience, which forces a close relationship with sectors outside the health sector or besides the health sector. Here we see an old psychiatric hospital in London. And today what we want is to turn this into a general network with community mental health equipment, where response is more social, more residential, with halfway homes, rehabilitation homes, and afterwards with primary care facilities, and below with institutions in this new community that have many resources that sometimes are hidden but are still very important. Today, we have thousands of papers, of articles, comparing models in the community with traditional hospital-based models. The advantages of the first ones are quite evident in terms of treatment compliance and adherence. A clinical framework, quality of life, accessibility, care continuation, service flexibility, and protecting human rights. Now, what has also happened is that for the last years, we've had new contributions that help rethink and reuse and use new care models, attention models. I'm going to try to summarize the main contributions for which we have evidence, sound evidence. The first one, the first important contribution was what has been called in English task shifting and step care. I don't really know how this is mentioned in English. I would say redistribution in task. So mental health teams, and not only mental health teams, but in general, they can redistribute tasks. And this has had a very important significance, all in emerging countries as well as developed countries. And we also have a step care that has helped us have a rational care with the possibility to ensure care continuity. This is especially evident in the collaborative care, the model where the specialized services work along with primary care in a systematic way, using this task shifting and many times the stepped care. Now, this is characterized by a screening, and persons that are identified with a mental health issue go to a program that's organized. So you can go from the most simple, least serious problems to the most serious ones to ensure this rational usage of resources. And we also have case management. This is the key of a person that manages the case. Now, it is important to add that we have very sound evidence. You could find excellent stories showing that collaborative care is the most effective way to treat especially depression and anxiety. But it's important to recognize that the implementation and practice in most of the countries is modest, so to say the least. This is a complex, complicated change. It is not simple at all. And incorporating collaborative care is complex, so a lot of things have to be done to achieve it. Another interesting model was the supportive employment. So this is a completely different way. Instead of preparing people to go to the job market, we start by putting people at the job market or employment market with a full support. And all of the studies, many of them today, show that it is way more effective than traditional methods of supporting employment. And what's funny is that it does not only ensure more work for a mental health, for people with mental health, and to have better clinical results and better satisfaction. These new support models, as well as the supported accommodation models, being new, I would suggest all of you, if interested, to go over Helen Gillespie articles and papers to see what is being done. This is a systematic type of document that better shows all of the potential that this holds when properly done, and the contribution that it could offer for persons automation and the complex cases. Here you can see that 2/3 of the cases that traditionally were thought that there was nothing there, or with resources and doing things properly, we can have a highly appreciative success. And I would like to conclude this brief summary talking about two models that are more recent. One of them is peer support, models involving people having experience in mental disease and in service provision, and in new models to reduce the use of coercion at a hospital and forced stay. This peer support is having more and more recognition every time. And we already have meta-analysis and systematic reviews that allow to conclude, for example, first, that there is no reduction in care quality. They are interrelated to clinical results that are more or less equivalent to traditional results. And there are several revisions suggesting that these support interventions, such as peer participation, are more effective in results related to empowerment, quality of life, etc. And this is understood because these are people that have way better experiences compared to those that have serious mental diseases. In Latin America, there are two countries, Chile and Brazil, that did studies on the use of peers and the CTI and the support model to the rehabilitation of those people hospitalized. And I am very excited with Rio de Janeiro and Santiago in Chile, what they are doing. And my experience, well, we are in the initial stage, but there is a huge potential. On the other hand, there are several strategies that allow reducing the use of coercion, not only treatment-wise, compulsive voluntary treatment-wise, but also there are other containment ways that are reduced. Of course, here we need to combine advocacy and, on the other hand, incorporate evidence-based interventions. For example, the advanced care directives or joint care plans, or for interventions in committing services. And there are many studies on this strategy that show that they could significantly reduce the use of coercion. And of course, this has to be simultaneous with mental health systems amendments and with changes in legislation and increasing the participation of patients and having the possibility to develop more research and create new processes. These are things that some years ago would have been impossible maybe, or appeared to be impossible. But today we are more and more developing in interventions all the way from mental health care models in several parts of the world. And yes, for 5 or 10 years, in 5 or 10 years, this won't be used anymore as a routine in many countries. And I am going to conclude my presentation by reiterating my appreciation for giving me this opportunity. Thank you very much. Thank you very much, Doctor. What you have said is quite interesting. And the advocacy, as you very well said, how many patients could be empowered to defend their rights and to participate in the organization of care, which is fundamental in the organization that we've been experiencing in Mexico. Thank you so much, Doctor. I think that you have given us a very broad overview that will be interrelated to the next presentation. And I think that case management have been fundamental aspects that we are already experiencing here in a very interesting way. Thank you very much, Doctor. Now I would like to introduce the next speaker. She's Dr. Lucia Amelia Ledesma Torres. I am going to share a summary of her resume. Dr. Ledesma has a PhD on neuropsychological changes in patients with resistant psychiatric pathology. This is a special mention. And she's also worked in emotional psychiatric response. He has also postgraduate studies in health psychology, bioethics, neuroscience, among others. She is a psychologist with a specialty in the clinical area. Currently, she is a national lead of mental health at ISSSTE. She's in charge of the emotional support and humanitarian support program for COVID during COVID pandemic. And she is an honored member of the Council on Psychiatry, and she has worked at the Faculty of Psychiatry in UNAM, and she is attending the high specialty in developed psychiatry. She has studies in collaborative clinical psychology and psychiatry at UNAM, and she has postgraduate studies in the Polytechnic Faculty of Medicine and in the Pan American University. She has postgraduate studies in medicine and neurosurgery. She is an expert advisor in psychiatric matters at ISSSTE. Doctor, please go ahead. Thank you so much, Dr. Gonzalez. I am ready now. I would like to say hello to Dr. Caldo and Dr. Soto. It is a pleasure to share this roundtable with you. I would like to thank the organizing committee and all of the honorable attendees that are following us via social media, and especially our fellow friends at ISSSTE presiding this Congress. So I will be talking about advances in the reformulation of mental health and addiction care models for the case of the ISSSTE. Now, the content of my presentation for these 15 minutes is addressing what the ISSSTE, especially for our foreign attendees and also colleagues from other countries. I will be talking about background, reformulation, and of course, part of the progress that we've had in this sense. Now, about the ISSSTE, our honorable institution was created in 1959. It is the National Institute of Security for the State Workers, and through a reform on the law in terms of health services and benefits, we've integrated our institute via 21st services, benefits, among others, for a total of 13.7 million users, account holder around the country. We currently have more than 1,121 units in total. Most of them are focused in the first level of attention. We have more than 200 units in the first level of attention. In the second level of attention, we have around 12, and the third level, we have the remaining number. And part of the user profile is focused mainly on users that are that are older than 60 years of age, where we have approximately 64% of all of these users, account holders, I'm talking about the 13.7 million account holders that have some sort of disability or circumstance related to psychosocial disability or mental health. And we have some background that are known for everyone in terms of reformulating models in terms of health. And we have also a reformulation that started since the end of the 70s, beginning of 80s at Alma Ata, where the paradigmatic change surrounding the important role in terms of first level of care of primary care of health was already proposed. And modifying and reformulating national and international policies, international cooperation, aspects related to the modification of the concept of health, where we already address well-being, for example.
On the other hand, parts of the development objectives had to do with eradicating poverty, hunger, and access education universally, to promote equality, autonomy, to improve everything what has to do with vulnerable groups, especially with people with HIV, other circumstances that puts them in psychosocial vulnerability. Also another background, Article 4 of the Mexican Constitution, who has talks about the access to to these health services. What Dr. Calas was mentioning regarding implementation in the case of Mexico, we have laws and aspects regarding law and norms, but there's still a lot of work to do in implementation and offer integral services that include the component of mental health. So we know that mental health is for everyone, that we are breaking the paradigm in this sense, and where we have other variables that have to do with economical and social, cultural aspects. And with this image that summarizes what the stigma has been, the confinement of users, patients that have been in hospital models that do not correspond to what someone needs, with different affections regarding their mental health or different needs. Part of this reformulation that have been commented throughout the Congress, how they have been changing this paradigm, that we try to fill the gap through proposals of the WHO collectives that have been transforming these models, the development of the Sustainable Development Objectives, also peace, justice, social development, and others, and also the great role of primary health care. As the conference of yesterday, one of that was magnificent, Dr. Sotelos, who has been one of the founders of these new reforms. And I wanted to share there's his credit and there's his information about the central points about the reform in Mexico to include these implementation matters and crisis situations, to eliminate the psychiatric model, to know that it has nothing to do with this integral care. Also the access for hospitalization in general hospitals, to support all of these matters and the developments with these axes, the success cases. In the case of ISSSTE, we have the reformulation of mental health care, who has a breaking point which is very important. In March 25 in 2021, we approved the integral program of mental health for 3 levels of attention. Since previous years, we've been working together with leadership and many milestones. We achieved to articulate the transversal strategy for well-being, which is primary care at 3 levels of attentions, breaking paradigms regarding primary care. Only for first level care. We know that it should be at all levels and with the component of mental health included. We've been working on this for many years. We have more than 300 teams. That's Echoes for Well-being. They're working at all levels of care and also at a community level, integrating mental health with models that have to do with collaborative methodology. Community teams of health and has as its objective to implement the primary care model of Echoes for Well-being in the services given by ISSSTE to guarantee accessibility, availability, and quality of care for the population. What Echoes pretend is to reach all communities and give health awareness. So this has been part of the work we've done in the last years with a accumulated experience with a coverage that has more impact, and that it complies with the new model of mental health that cares about the efforts in the first level care. We have departments of chronic diseases, support groups, prevention campaigns, where we also include the whole mental health methodology. And these are just some examples of the materials we have also for Mayan speakers to cover accessibility, 3x1 campaigns, which are what we do throughout different years. Sorry, I'm not able to listen to her because of the video. This is to create awareness of this campaign. Campaigns like Together Walking, Without Sugar, etc. These hikes also help the cerebrovascular system, which also tends to affect population we're working with, and we break also paradigms about the mental health aspect where it complies with, has a transversality in the different programs that we have from other health components. The creation of the National Center ECOS, we have a specific center with this component where we are very proud of. There's part of the team operating in other units. In Tláhuac, we have 16. Sorry, I cannot understand her because of the video. It is approved for the first time the integral program for mental health for the 3 levels of attention. Here we also see part of what other incorporations have been, that the ISSSTE has given, like the incorporation of the first humanoid robot and mini robots for mental health care during the pandemic. Another important project. Sorry, I cannot understand her because of the video.
Harley y el Tuerto. Terapia afectiva asistida por Canal Personal Sanitario.
Sorry, I cannot understand her because of the video. The program of orientation and counseling in mental health for staff is still on. We are taking care of staff throughout the country. We also create interventions for schools throughout the country, and that they get incorporated in trans-pandemic periods. We are talking about the 25,000 schools. Many children are having this social emotional support in their classes, the schools and their dynamics. Harley also is another project. They're trying to establish working communities and healthy through this message that comes from the interventions. ISSSTE as such has had its own intervention with canines, with research. We have another program in 20 de noviembre with oncological diseases. We also have published articles about the effectivity about it. We continue working with these innovative interventions. We also have many canine co-therapists. We have Bear, Tango, Luke, and all of the canine psychotherapists that have been supporting us in other type of interventions in hospital areas, communities that are double vulnerabilities, as the image you see there. We also have other interventions regarding with the detection of addictions, early detection. Also many services to stop tabachism. More than 150 clinics to stop smoking. We have our specialized clinic for HIV patients, where we have psychology, psychiatry, neuropsychology services. Our orphanage program, another vulnerable community, where we're working a lot with the mental health component, mental health for migrants, where we're working in Oaxaca, where we're attending this need as part of the interventions in the community. We have one of the achievements we are very proud of regarding mental health. With the publication of this reform becomes more strong when implementing the Guide 20, the management of emergencies, Purple Code. We have implementing it for 1 year. With the support of human rights, more than 1,000 cases attended. The youngest was 9 years old with attempt suicide. Colleagues, workers have been benefited about this care. Physicians, more than 150 beds in all countries, 3 hospital units with specialized equipment and courses for resident physicians. Also integrating the Purple Code network at all 3 levels with the objective of having a quicker response. Regarding these high specialty aspects, protocols for treatment with severe addictions in 20 Noviembre, the incorporations of surgery, also the including our integral program for preventive care. Also, we have been working 1 year with this center and all 3 levels of attention. Also participating in COVID areas. And we see a lot of examples and success cases with a lot of efforts with the team, where mental health, without a doubt, is part of the inclusion that needs to be present in our interinstitutional interventions. Part of the guidelines we are very proud of. They have the component of mental health included. The relationship and partnership with many sectors. Here you see image of IMSS Bienestar with the partners that form the technical team federally of people from Secretary of Salud, colleagues that somehow have added their efforts there we see in field. And it has been a historical moment for mental health in Mexico. Part of these linkings with the systems, this is a recent image about the Congress. We have collectives and NGOs. This is one of the biggest ones for motion discapabilities. And also the updates and continuous education, where we include everything we've talked about, teleeducation, our adaptations depending in our different regions and culturalities, our update for staff of mental health, our participation to the general program of teleeducation, our course for first responders, we have now in the whole country, and our achievements in infrastructures where we still have a lot to do, but we've reached these achievements. The units of mental health in general hospitals, the secure distribution of hospitals, in Tláhuac, where we have 96 of 100 points. And to remember to include bioethics regarding mental health and the Human Rights Act, which highlights this mental health area we have in Mexico, remembering science and conscience. This is how we can make changes. There's no health without mental health.
Y recordando el gran esfuerzo interinstitucional.
And remember the interinstitutional efforts. Their homage to Norma Palacios, who without a doubt has been an important column for this interinstitutional effort, with Eastern Secretary of Health, IMSS, Bienestar, and SAVI are all together doing their work, and all the international consultants that have worked here. Thank you, and greetings to all of the teams that are following this Congress, and congratulations for your efforts.
Muchísimas gracias, doctora Lucía Ledesma. Impresionante la
Thank you,
cantidad.
Dr. Lucia. Impressive. All the implementations. It's a huge challenge throughout the whole country. So congratulations. We have some questions. We're gonna wait for the end. Let's present now our next speaker, Dr. Gonzalo Sotobrand. Currently, he's Ministry Secretary of Health of the Metropolitan Region of Chile. He is psychology by the University of Chile, teacher of public health, professor of public health from the University of Chile, first care attention by the School of Medicine of the University of Chile, and a diplomate of social determination for health programs by Flaxo. He has been academic coordinator of mental health and community psychiatry in the public health school, Salvador Allende, mental health coordinator of primary care in the Ministry of Health, and consultant of the subsystem of Chile Grows With You of Mental Health Ministry, consultant of PAHO, and a great participant in different research projects linked with mental health. Welcome, Dr. Soto. Go ahead. Good afternoon. Thank you, Dr. Gonzalez, for your presentation. Thank you for the invitation of being part of this activity organized by our brothers and sisters from Mexico. Also, thank you, Dr. Felix Garcia, for the invitation, who was involved in the Congress organization. Very glad to hear Dr. Calva Almeida and Dr. Ledesma. I'm gonna share my screen with the presentation. Can you see it? You can see it, correct? To start, I would like to share a thought about the advancements in this matter from the experience of Chile and also the countries of the region who have influenced in this process. Maybe some ideas that we heard from Dr. Almeida regarding the conceptual framework and the attention model. Considering a century back, the model is still the concepts that as were understood back then. And sometimes these mental health services was only the madhouse houses. It understood a biological origin, and in many parts of the world, they developed psychiatric hospitals as a response to this problem. It was also that mid of last century, these systems started to change, because not only for mental health we saw these problems. I visited other countries and we can see the whole hospitals, these neurological and psychiatric hospitals, and we can see how we used to see health and the cosmovision of this conceptual framework of health. And then after the Second World War, that perspective was abandoned to more integral services and with more integral perspective. In the 60s in Chile, we had a psychiatrist that throughout Europe, he got this new perspective. And when he came back, he developed a more communitary way of seeing health, to lower attentions to the territories and turning into communitary psychiatrists. He had the view to develop these type of hospitals in Chile in the 60s, to develop also ambulatory services for mental health patients. And that marked in our country, and it influenced other parts of the regions to start implementing this new type of model. And also known by everyone what Basaglia did with the Italian reform in '78, and what it meant to move to a model more centered in communities, in people, and abandoning the psychiatric hospitals. Also an important moment for our country in the Americas in the 90s, when we achieved to have this regional agreement with the leader by PAHO, and to move forward with this model that came from the madhouse to the ambulatory treatment, and that was the path to follow. And also some things that here in Chile we had for many years. Dr. Alberto Milenetti, Chief of Mental Health, and he was one of the leaders of this reform. And from then on, he achieved important advancements to achieve a change in this care model, to achieve the different, to reach the different levels, to have territory care in the community, and that it implied many obstacles because it was a very difficult transformation. In the National Psychiatry Plan, other manuals of primary care that has been there for almost 20 years. Also, care for depression with intervention based on evidence, not only with psychologists, but other health professionals that are important to be included. And then 2 mental health plans for that it will implement until 2025. in the general network of health, how to integrate the mental health to the rest of the system. That's why we have this integral model, and maybe this was strengthened in this region with all the integrated networks. We have a diagram on how these models should be developed of the sanitary system, where we have to give certain principles, and we have to see to care the right continuous work at all levels, and also how here in Chile it was inspired the new model. It's very inspired of what PAHO recommended, a health system that it was interinstitutional with a family approach. Also, the integral care. There in the national system here in Chile, we achieved to have this primary care. We have more than 2,000 psychologists. So there's one psychologist regarding these mental health matters in a primary care establishment. We changed this model of a perspective, the demographic profile. To attend these chronic and mental health issues, we have a historical diagram of how Chile advanced to this biomedical model, to now these community and family centers. It is very important what Dr. Sotelo mentioned, that one of the most important strategies, the primary care, and not only treatment of persons that may have health care, but also mental health care.
Sino que debemos poner también la acción en la prevención de salud mental y adicciones, en la atención primaria, la promoción.
So we also need to consider promotion, as well as being able to put all of our resources in the different baskets, which would be promotion, prevention, treatment and care, intersectoriality and recovery. So this would be the aspects that are based in a care model and showing more or less what we have in Chile, the comprehensive health community model, which is fused with the primary care model. And also it's important to add that the integration of mental health and addiction in primary care is something that holds plenty of evidence, as the doctors before me have already mentioned, having to do with community model network and informing community agents, and also going back to the recommendations that the WHO already shared with this document that has already been published since 15, 20 years ago. So the idea is to consolidate that it is truly based on evidence and that there is effective results in integrating mental health in primary care and addiction. For example, in our country, in Chile, we have addiction care in primary care services for substance abuse, tobacco, marijuana, alcohol, etc. The main aspects in the health community is that attention, since it's going to be strengthened and focused in territories, and this is going to be by means of the strategy. So it has an important pillar centered in community, and there is a recovery, as it's already called, so that people can truly integrate to their environment, as well as a reformulation of mental health services network because primary care means that all health sectors have to be involved in mental health services, especially providing mental health services, as well as emphasizing on prevention of mental health problems. This also can reproduce the idea of care model prevention. And here we have a pyramid that offers the less amount of hospitalization services, so they are reserved for truly complex cases, and the least amount of population require them because they are more expensive, actually. And there has to be an intermediate case with day care, and in the lowest level, we will have community mental health community centers where it is important and the most population could attend to them. And we also have the primary care network where there should be mental health services provided. And one of the strategies that I've seen to be effective during this Congress is how the integration of the NH Lab has been in the primary care setting, which has a high evidence of it being a great tool. And the community recognizes and detects the needs in the sector, culture, sports, that are very important for people, and that allows them to lead their mental health problems. And there is an example here on the progress of care models, mental care models in Chile. So you can see how during the 90s, for example, resources destined to psychiatric hospitals was quite high and quite low for ambulatory or outpatients one, which was for primary care, quite similar to the one that we have implementing today in Peru. And we can also see how in time, the expenditure in psychiatric hospitals was reduced. And this was a very important development that has been achieved in previous decades. And Chile has been strengthening this distribution where resources today focused in outpatient settings, and that's the right way to go. Here, I would also like to mention the diagram of PAHO, reinforcing that in the framework of the Health Services Integrated Network, at the center, we have the first level of care, which is primary care, which is the connection with the community and territory, with families and with the individual. And from there, the specialty care is deployed, but that's where there has to be mental health care. And there has to be also interaction with other sectors. In Chile, the documents for network reformulation, we have this scheme reproduced, which is in the new plan of mental health that has been working for 4 years. And it mentions that mental health care, it has to be in the primary care services. And in Chile, these are the different way of outpatient centers that we have. The mental health care, community mental health center, the community support center for people with dementia. And this is also an intensive care unit that can also offer those services, especially psychiatric services for adults. Unfortunately, not all of them have it. So as you can see here in a particular scheme, shows the recommendations that have been done for our nation. But in this scheme, we don't have psychiatric hospitals anymore. But Chile still has 4 psychiatric hospitals. But there is this national reformulation plan that aims to turn them into an outpatient center where there's intensive care and closed hospitalization at General Hospital, which is a process that's ongoing today, considering that in the administration of President Boric, mental health is very important. And with this, I conclude. This addresses the challenges of having a wider conceptual framework, which includes health social determinants. Here we have a brief scheme with some publications in 2002, 2012, and 1995, where they attempted to state what determined the process of health disease. So if we look at 1995, we see the weight that service providers was given. Healthcare, 43%, other factors, 57%. So as you can see, as time goes by, in this research, we see that other factors determining the state of health or disease of people is stated. And we see that there are other circumstances included related to social, environmental factors, behaviors. And in 2012, we have this advanced research effort by the Canadian Institute that talks about healthcare, socioeconomic, environmental, etc. So maybe in this conceptual framework, we should see what has to be at the basis. And this is the one promoted by WHO, where we see social determinants that are structural, and we also see social determinants that are intermediate, where the health system that's here down to the right is an important part. So we need to consider the other conditions of health and mental health that have to do, for example, with socioeconomic position, social class, gender, visibility, profession, public policies. And this is a huge challenge because you realize that in order to address mental health, of course, the health system is a very important aspect, and we need to reformulate a care model, but also to have an intersectorial model, coordinate with other sectors so that we can promote, as Dr. Calamira was saying, include some evidence-based programs, like the integration with the world labor sector that has to do with education, labor, as I said, and together there can be an agenda that allows people not only recovering, clinically speaking, but also with the most comprehensive system to be able to provide a comprehensive response. And the community model is a fundamental pillar. And participation is also very important because with participation, we are going to see how to better reach people and the best ways for them to also participate, for example, in designing public policies, and not only knowing the informal aspects, but also so they can participate in formulating them. And with this, I conclude. This is a document that was published a year ago in 2018 that talks about social determinants of mental disorders and sustainable development goals. So for some mental disorders, for example, this one that has to do with trauma and distress, it is very important not only to address social factors, the closer ones, that have to do protecting people so they are not exposed to this type of situations, but also the actions that you can take that have to do with, in this case, preventing natural disasters, climate change, generating action plans, generating protocols in situations such as the ones affecting people. There is a lot of forced migration, generating plans that could mitigate the impact. And this, of course, is also including SDGs, which is important at a macro level, because a challenge could also affect our care model in order to work with other sectors and with other departments. Sorry if I went over my time, but I'm very thankful for the invitation. Thank you, doctors. Thank you, Dr. Gonzalo Soto-Brandt. Your experience of reformulation is quite interesting. I believe integrating this view is indispensable, and there is already inertia towards the entire hemisphere, so we have to grow, and we have to reduce the gap in mental health and in addictions with this effort. And of course, I find very interesting in the way to go from biomedical models to a more biopsychosocial model with a focus on community. There's a lot to do still. Thank you so much, Doctor. Now I'm going to pass the floor to the next speaker, Dr. Norma Magdalena Palacios Jimenez. She is currently Chief of Project Management in Health Innovation Department at the IMSS. Dr. Palacios is a surgeon by the University of Guadalajara here in Mexico with a specialty in internal medicine and infectology by the National Medical Center La Raza at the Medical Institute of Social Security with PhDs and postgraduate studies in innovation management, informatics, etc. Dr. Palacios has been in charge of coordinating and promoting the comprehensive program of mental health at IMSS since 2021 until today. She's a member of the Sectorial Command of Health, that was mentioned in Dr. Lucia's presentation, head of the IMSS Department on Health Prevention, and chief of the technological area for management, for knowledge management. So Dr. Palacios has been a pillar in promoting and reformulating mental health as we know it. So thank you so much, Doctor. Please go ahead. The floor is all yours.
En un breve espacio podremos revisar algunas.
At the end of this presentation, we will be able to go over the comments and questions. Thank you so much. I would like to thank all of the panelists for joining us in this roundtable. And I would also like to thank the attendees that are staying with us despite of the time, because there are still many people connected. So I am very thankful and I appreciate your presence. Next slide, please. I will be talking about what we're doing at the IMSS. You know that this is an institution that has more than 80 years functioning. In 2023, it will have an anniversary, the 83rd anniversary. And from the beginning, it has implemented many programs having to do with prevention, health, promotion, and I will focus on mental health. And this first slide talks about the dimensions that IMSS have. The institute is throughout the national territory. We have more than 1,500 first-level units, 250 second-level hospitals, 25 medical units of high specialty, and 11 complementary units to these high specialty hospitals. Human resources-wise, we have in the first level more than 19,000 family doctors, more than 40,000 non-family physicians. These are doctors that have some other specialty. And nursing, we have more than 115,000 nurses. Social workers, we have more than 5,000 throughout the territory. Now I'm going to go to the next slide where we have the infrastructure. We detail clinics. Well, now I would like to detail two components that I find critical and that are pillars of what we are implementing today. At the Institute, we have 2,686 modules called Prevenims and 1,032 modules of nurses specialized in family medicine. And later on, I will describe what is the work done, especially including the mental health components in these spaces. We also have 139 modules that have to do with prevention, promotion, and care for the Institute's workers. On the right, in 2021, we see that IMSS provided 79 million consultations of family medicine, 14.2 million of specialty consultations. Among the first motives or reasons to look for the IMSS support we have mental health disorders and behavior disorders. They hold the 10th place in family medicine and in specialty the 6th place. To our right, we have a graph, and what you can see there in 3 different colors is what's provided today as a first level care. That's the blue line. Those are the consultations in related to mental health, both in emergency and in family medicine. They want to show the huge gap between the first and third level of care. So most of the care in mental health, well, the entry would be the first level, which is the first contact point with the family physician, family medicine. And from human resources point of view, I would like to show this specialized health staff graph where you can see in green the psychologists that we have worldwide, and in brown we see psychiatrists. As you can see, and I'm sure this is the same for every institution, the specialized staff is located in a hospital-based approach. And in the first level of care, we have around 110 psychologists and psychiatrists, only 8 in the first level of care. So I was saying that the first level has more than 1,500 units, and this is how they are distributed. Psychiatry hospitals, IMSS has 4 hospitals. 3 of them are third level of care because of the services that they provide, and 1 second level. 3 of them are in Mexico City, and another one is in Nuevo León, which is third level of care. And in Mexico City, 2 of them are third level and 1 is second level of care. Next, please. Here we have the organizations of services and the human rights infrastructure. You will remember what we experienced in the framework of the pandemic. All of the institutions have implemented a series of actions in order to mitigate the effects of the pandemic. The IMSS was no exception. And the coordination of first level of care in collaboration with other institutes, departments, implemented and developed the action plan in mental health in the context of COVID-19. This action plan had 5 main pillars. The first was training staff in mental health services, especially the first level care. The other pillar was implementing telephone care on mental health via the telephone medical guidance. And here we have some of the numbers achieved with this tool. Another pillar that was considered strategic in this action plan was strengthening mental health attention paths for account holders. So a series of guidelines allowing standardizing the process of care were written now by the mental health groups and by the staff that was located in the different levels of care. We also worked closely in providing mental health care to the staff that was directly providing care to patients. And the number of human resources that were specialized increased. Psychologists were hired for second level care so that these provided care to the staff that had any stress situations, anxiety, secondary to addressing patients with COVID. And the work carried out in EPETIMS models were also carried out, channeling patients with mental disorders. All of this was done during 2020-2021. As of 2021, the High Directorate requested to start working in a program that interrelated all of the actions that were carried out in a disarticulated way in the different areas and departments of the Institute, basically the medical service providing. And there was a comprehensive program on mental health with 3 main goals. The first goal was systematizing the promotion and care of mental health in the 3 different levels of care, including the community, to improve quality and timely services at the Institute. Expanding mental health and addiction services to cover the gap between the current offer and demands aggravated by the pandemic. And third, guarantee equitable access to mental health and addiction care in account holders. And these are the important bases for what we are doing in terms of mental health at the IMSS. We all know, for example, the change in public policies. All of the speakers before me have talked about them. There is a change in policy and a specific program of mental health and addictions that was prepared by the Ministry of Health, and they are the guiding institution working with other departments. And these policies emphasize primary care and respecting human rights. We also have the amendment to the General Health Law, which provides a very good foundation for the actions that we are implementing in the Institute. And the other things, it was being presented throughout the day. We've seen many experiences shared by means of these networks throughout the states. And what I consider to be fundamental is to work in a closely and articulated way with the rest of the sector and with other sectors, of course, because implementing actions in terms of mental health and addictions, as you very well know, cannot be done by only one institution. So the health sector won't be able to address this problem by themselves, since it includes other risk factors. Next, please. And the program here shows one of the pillars, which is health, primary care. The other pillar is human rights, and the other pillar is the permanent interrelationship with interinstitutions, because we don't know it all, and there is no country nor organization that has all of the knowledge, all of the learning, especially in the territory and in implementation. So it is important to remain interrelated, to readdress best practices and lessons learned, and to work with the community focus. The IMSS already has actions via Prevenims and the CEPETIMS modules where promotion and prevention actions are held. There's another image that's quite small where I talk about the program. It's 3 goals, strategies, and action lines. And it is important because this is the map that's allowing us to work in an organized fashion and implement actions that are the result of the program. These are the main elements: health, prevention, and promotion, the early detection of mental disorders and disorders related to substance abuse, timely diagnosis. The importance of early diagnostic has already been mentioned to prevent disability, and of course, improving the quality of life of people. Another main component is a comprehensive treatment by the multidisciplinary team. Other elements that we consider to be the basis of the latter is sensitizing staff and population, because while the population doesn't have psychoeducation and they do not understand mental health, which is a condition that any person could show, and you don't have to feel discriminated against, stigmatized, or different due to this. And we have to work a lot on this. We should train the entire health staff from first, second, and third level of care. According to their profiles, they need specific training according to their activities carried out in the care process. Also assessments, so we can improve what we are implementing. And there is another component where the CISS and the CIESS are very important, which has to do with research surrounding the implementation program and standardization and regulation. There is a regulation that was done with a specific focus, which is completely different. And we have to transition towards changing a model and a vision that considers mental health as critical. What I'm showing here is a timeline discussing the problem that the Institute has faced historically with the data that I previously shared. I'm sorry, because I was distracted by an urgent phone call, sorry, but let me go back to the presentation. The first thing we did facing this problem was carrying out a situational diagnosis and recover the installed capacity. We looked at the problems that the IMSS had, the level of training, where we had to reinforce our efforts, and the other important aspect was to start working with the psychiatric services in an interrelated manner, with the National Commission Against Addictions, with the National Council of Mental Health, all of them at the Ministry of Health. And of course, we approached PAHO to receive the right training with the CISS and the CIESS. The first thing that we considered to be of utmost importance and that we realized that was inexistent in the Institute is that we needed a standardized way to detect the main mental disorders that the account holders could show. So we implemented a pilot programs in Coahuila and Aguascalientes, and we worked with first level of care institutions. What we did was for this screening to be implemented by the nursing department. Actually, once this instrument is applied after applying the tests of diabetes, hypertension, etc., the breast cancer, and any other detection, what we aim is to integrate also detection of depression and anxiety, which are the main disorders that we have identified in account holders. So we have trained this group of nurses in these two states. We implemented detection and we obtained results. And we did around 800 screenings at that time, and we found a prevalence of 13 to 14% of anxiety, similar numbers, 6% depression, and the two combined around 13%. We then trained the nursing staff at Prevenims modules so that they were able to start implementing this detection at a national level. Also, with the support of PAHO at WHO, we trained the first human resources, the first level of care mainly, in the MHCAP guideline, because it was a huge challenge because there's always resistance. We did experience resistance mainly at the first level of care. They told us we wanted to turn them into psychiatrists and psychologists. The physician already had a lot to do, and we were going to give something else for them to do. After the sensitization work, we were able to integrate some people to this training, and we considered them to be our first facilitators. Simultaneously, we started working with the nominal census of mental disorders and behavior, and we identified the number of persons per state and per medical unit that had some of the main mental disorders. We were able to integrate the census, and something that's important and that I did not mention before is that we integrated a high-level technical team. Actually, with me, I have a doctor that has permanently working with us, Dr. Valle, and other psychiatrists that have been helping us in our day-to-day effort. And last year, we wanted to launch our comprehensive mental health program. And what we proposed was doing it during the first International Congress of Mental Health, which slogan was creating a flagship and allies. And it was important for us to share this with the national and international community, what the IMSS was doing, and also readdressing the best practices of our countries and other institutions to strengthen the actions that we were implementing at the IMSS.
A la par desarrollamos
Together, we developed a course to train the staff of first level care that has to do with the MHCAP intervention guidelines. In 2021, we trained the first family physicians and also some nurses, but we believe it was important for us to have our own courses to implement, and we developed it with the IMSS. Particularly the coordination of well-being, and it is a course that have to do with its implementation from this year. Also, we need to make some reasonable adjustment to implement them within these institutions according to the institutional processes. Oh, we need to also detect depression, prevention, and panic disorder in Prevenims. This is important. There was a relaunch on Prevenims, the program. It was Prevenims Plus, and there we integrated the detection of mental disorders. This year, there was a deployment nationally from August for these type of disorders in all first level care units, companies, schools, and effectives models. Because something we believed it was very important is that we need to use the detection in certain sectors where someone requests for this service, they would detect it of some of these disorders that are more frequent. We also promote materials for promoting mental health, and we have an agreement with CIS to strengthen the implementation of the integral program of mental health. And with PAHO, we are going to sign another agreement. We have also brief interventions for specialized physicians so that the medical staff of Prevenims know how to approach the most elemental part with someone with suspicion and how to intervene. From the point of view of the frequency of hard data, what we have in IMSS, in this survey, in this graphic, what we can see is that the most common one has to do with anxiety and obsessive compulsive disorders. The second one is depressive episodes. And the third one, we have mental disorders because of substance abuse. I would highlight here that 20-year-olds and older that are part of this survey, 2,321,145, 80% of those had anxiety, 3% had depression, and other disorders in lower percentages. The average age is 52 years old with for the census, and 71% are women. Here is just to highlight, we remove the anxiety part so we can see it more clearly. And what we're doing at IMSS at first level care, first of all, to work with the teams, the multidisciplinary teams, to train them so they can do the best approach from the first level to integrate detection about depression and panic disorder, to reinforce in the first level the diagnosis and pharmacological and non-pharmacological treatment for the main disorders, to implement strategies to promote healthy life habits, and also education. These are actions already being cared of, but we need to strengthen them because, as you all know, it's an important column for mental health, to have informational materials to promote mental health, and something that has been said, to work with the vulnerable groups. I'm going to go faster. The tools of the first contact physician, they have the MHGAP guidelines. The materials is there to get training, and also materials worked since 2020 that was updated in 2021, where we talk about the main disorders and recommendations of for medication. We developed materials to promote mental health, brief interventions, and some educational programs with chronic disorders. We've achieved to have a good work within IMSS. It is important to work within all areas, and that's what we've achieved, to have better linking at all levels between nursing staff and other norm coordinations. Also to train our medical staff and social workers in MHCAP throughout the platform where we have this course right now. It has been a lot of subscribers. Also to have drugs available from the first level, we have 14 keys for antidepressant and anti-anxiety. And third is the filter of a panic disorder in population of older than 20 years old. Through EFECT teams, we bring care to workers and do more than 32,000 filters. And in some cases, it was found the anxiety and another depression. And this has been done in a couple of months. And this is what we've achieved until now. In Prevenims, we've worked more than 800 detections. This has been complicated work. There's a lot of resistance by the youth.
Tan sencillo, hay que seguir trabajando en la sensibilización y concientización. Y lo que
There's still lack of awareness about mental health. Around 6% suspect of depression or anxiety, and this is important because when there's suspicion, they have to be channeled to their physician so that they have the diagnosis, they can start treatment, depending if that's a severe case or if they need to be supported to second or third level. Another action is the Congress we've had. This is the first Congress in 2021. This was to make alliances, and we projected to have 1,500. We had almost 7,000. We have the participation of more than 10 countries. This year, we're amazed about the participation. The matter of mental health and addictions is of high interest for all institutions, for all countries, because we can have a lot of around 17,000 subscribers. We had a lot of more than 44 experts and 12 moderators. Where are we going? What are we missing? A lot. Actually, there's still a lot to do. From starters, next year, the big challenge is to work on the mental health component in their institutional command. The second one is the action plan against suicide to implement Code 100 in hospitals. Third one, to strengthen detection and attention of mental disorders because of substance abuse within IMSS workers. And something important, to have action plans that are very standardized and very solid to attend emergencies and crises. We've had some situations, we had a COVID, but within IMSS, we've had some other situations that oblige us to be prepared and have first responders to these critical situations. Also to have to work on mentoring by specialized staff, psychiatrists from IMSS. Some of the considerations, I believe this is a good path. After 3 days of listening people from many parts of the world and listening colleagues from other institutions, we believe that we are going through a good path. It's good to value our actions. I think no one has absolute truth. We have to rethink and improve everything. We have to keep on working with these complementary teams. I think we cannot do it alone. If we don't work together, it's complicated. There's still a lot to do, but there's will, commitment, and a lot of work behind. And we will continue with these congresses with good practices and lessons learned. Thank you very much. Thank you, Doctor, Thank you for your presentation. It's impressive. This need of the redistribution that IMSS has had, and that it represents resistance to a lot of levels. But this intervention comes from the first level of attention, and detection of the cases is important. It is important to answer the call of Dr. Gavallesus to join the call to take action, to take care of mental health. It involves the interinstitutional work to take care of all these social determinants regarding mental health. We are short on time. We have some questions that have been asked, but I believe that we are not going to be able to attend them. We have the final presentation of this Congress. We're going to give the questions to the speakers so that those participants may have answers. Thank you very much. It's been an honor to be here. Dr. Caldas, Dr. Lucia Ledesma, Dr. Soto Brand, and Dr. Palacios, thank you very much. I believe the experience of this Congress has been unique and it's going to grow. This has to continue throughout the whole region. Thank you very much to all. And I'm going to give the floor to the coordinators. Greetings from ISTE, from our mental health, and there's part of the team. Thank you for including us in this model. There we see one of our canines. So thank you very much. Thank you, Dr. Lucia.
Tras cada programa existe una organización formidable.
So in each program, we have this human and technological resource working together for Commonwealth. Well, thank you for giving us a new perspective of mental health. Now let's go to the closing. Joining offers, we can transform mental health. The concept of psychiatric hospitals shouldn't be seen from the previous model, but as an integral care center to give care at many levels. A place to learn and a training of the future representative of mental health. They need to have a strength in many areas with ambulatory programs and community psychiatry. Having a mental health without gaps, eliminating prejudgments and paradigms. So today, after 3 days of experts, we finish with a brilliant view, knowing that mental health is in great hands. So let's imagine next year. It is an honor for us to present this closing with past, present, future regarding mental health and addictions, actions from the health sector. We have Dr. Celida Duque Molina. She's honoris causa for her actions in favor of preventive health by the Mexican Institute of Leeds. Professor in high direction and budget based on results, specialist in medicine by Centro Médico Nacional La Raza from IMSS, medicine bachelor by UNAM. She is currently director of medical services of IMSS. Her professional trajectory: Chief of Medical Services in the representation of Mexico City, Director of External Ambulatory Care in La Raza, Coordinator of Hospitals of OAT, Director of HGC 68, Subdirector of 76 Zone Hospital. Also her achievements and it include the creation of kidney and eye transplant and metabolic diseases. Nice to say hello and to give you a message of the proffers that have been in this second Congress and adding efforts to know what we have done. I would also like to thank all the institutions that have allowed us to go through this second Congress, particularly Norma Palacios leading this matter, this Congress with great results. We reached 70,000 people from 20 countries. Of the collaborators, panels, roundtables, debates, 44 experts, and our moderators. Next slide. So what follows in this matter? Here we have some of the recommendations. The recommendations by WHO, PAHO, the restructurations, and that we have this legal framework that was applied, that it applies for 2024, the programs, and recently the institutional program of IMSS for mental health. So we know that we have different recommendations. We have very important contributions regarding mental health. And as Dr. Palacios mentioned, the detections in Prevenims. We also have to promote self-care. We were talking about this with ISTE, INSABI, Secretary of Health, and Dr. Palacios to take care of this campaign for self-care of mental health. And the important thing is the interinstitutional collaboration. This is the great impact that we see in mental health. The increase after the pandemic, the impact of early detection, why this intervention is sustained in self-care and community care. And then the services interinstitutionally. The gaps of mental health, we still have data, we still missing research to establish governance. We know this imbalance between the specialists and the increasing demand in our country and in other countries, and the coverage of services. We need to check this intersectional cooperation, and this is for the next year in all the institutions that you can see on screen, and also other institutions like the Inter-American Conference of Social Security. This is our program in IMSS. We established First, to establish the systematization of mental health at all levels. Also, to attend the community in all actions. We've been working with the reorganization of mental health and addictions. And also we've established the attention to apply some specific protocols. The second objective is for addiction between offer and demand. For sure, next year we're going to include in many programs of preventive actions, like prevention in schools, which actually have a great action
certain action
for youngs
in
and teens, where
population of youth, and others
we
where
can
we
do
are going to be able
follow-up.
to carry out these follow-ups and to enforce our program against addictions. Let me tell you that we have been using also IT to implement our digital consultation. And by this time, we have 1 million of digital materials, and its proposal to use this technology is for an intervention that we will be carrying out. The priority goal is number 3, which is the equitative progress of mental health care and for users and account holders.
En la que estaba nuestro director general y nuestros actores de diferentes instituciones del país, donde acabamos de presentar la política institucional para la atención de la salud de grupos en situación de vulnerabilidad con enfoque de derechos humanos y perspectiva de género. Esta política que implementamos en 5 grupos específicos que son justamente los niños.
And this is specifically boys and girls with cancer, pregnant women, older adults, people with some sort of disability. And this brings us to an important section, which is the percentage of people identified with disability will correspond to mental health diseases and illnesses. Next, please. And we were able to work along with the countries that you can see on screen. In our first Congress that Dr. Palacios just mentioned, where our slogan was creating a flagship and allies. And it was very important for the second Congress to have more participation from other countries, and we achieved that goal. We had a great impact in social media with 1 million of comments. And we had forecasted, since this was a first experience, 1,500 attendees. However, we had 7,000 participating from 18 different countries. Our first Congress was 8, 9, and 10 December last year. And our second Congress, I already told you at the beginning of the presentation, had great results, great attendee number for the benefit of our account holders. So we will plan our 3rd International Congress. We will see what happened for this last couple of years, what's next, and establishing and strengthening standards. We will be working with digital tools and with human rights approach, with a gender perspective as well. All of this in a framework of change management. Next, please.
We have many strategy and actions that we have to strengthen. Also, the participation of the society and increase of budget, for sure, for an important program as this. The collaboration, which is vital to have carry out these interventions, the intervention of promotion and intervention. At all moments, the attention centered on the individual based on human rights and their recovery. And also we were working with all community networks to help all the people suffering from this pathology. I would like to thank everyone and we'll see each other next year. And let's remember that there's no health without mental health. Thank you.
Muchísimas gracias por sus palabras.
Thank you very much for your words, Doctor. We are definitely all inspired, and we will share the ideal to look for mental health. It is an honor to have your presence and your participation, and we'll see each other next year. Thank you.